Good morning, everyone. I was just trying to wake everyone up. Well, welcome to our second annual State of Nursing Science Endowed Lectureship Symposium. We're really thrilled to have you, all of you here in person, as well as virtually from around the globe through our live stream here. And we're really excited that you are able to attend this wonderful event that we have planned for you. We have a lot of wonderful speakers and guests here today, so we hope that you'll be able to fully enjoy the entire day with us. To start, my name is Linda Kim, and I am the director for the Center of Global Nursing and Health here at UT Austin School of Nursing. And as I mentioned, I think that we're really fortunate to be able to be here and be able to share all this experience and to have our esteemed guests here as guest speakers to share their experience and expertise with us. So we're really, really happy to have everyone here with us today. And we are proud to highlight our endowed sponsors, the Laverne Gelman Lectureship in Nursing and the George and Diana Sharp Perinatal Lectureship. And we're also, we would also like to offer a special thank you to this year's newest symposium supporters. We have the Texas Global and Dell Medical School. So at this time, I would like to first invite our Dean Inok Im, to come and give us the opening remarks.
Thanks for coming. It's my greatest honor to welcome you to the second annual State of Nursing Science Symposium. Today's gathering is more than a symposium. It's a celebration of our shared commitment to advancing nursing science, global health leadership, and collaborative innovation. As we convene under the theme of global leadership in nursing and health, we are reminded of the power of nursing to transcend borders, cultures, and disciplines. Our speakers today represent excellence from across the globe, bringing the insights that will shape the future of healthcare, education, research, and practice. Since we have speakers across the globe, of course, I want to use this great opportunity for our school to shine. Yep, I'm the dean, so let me take a moment to highlight the remarkable achievements and legacy of the school. First, national recognition. Our MSN program was national number 6 in public universities last year. Of course, we are number 1 in Texas. Second, historical excellence. Our School of Nursing started from 1890, and our PhD program is one of the first PhD programs in the nation. Third, student selectivity. Our BSN program acceptance rate is under 3%. We are receiving more than 4,000 applications each year, and we are accepting only about 60 students. Fourth, faculty distinction. Our faculty are leaders in their fields, securing competitive research grants, serving the national boards of professional organizations, providing faculty practice through our own clinics with a long history of collaboration with communities, serving as the editors-in-chief and editorial advisory boards of prestigious journals, mentoring the next generation of nursing scientists, and so on. So many accomplishments that I cannot list all here. Finally, of course, global collaboration. This symposium itself is a testament to our global vision. Supported by Texas Global, Dell Medical School, and our own endowments, we are expanding our international footprint and forging partnerships that elevate nursing science worldwide. To conclude my remarks, I want to give special thanks to Dr. Sonia Fagenbaum, our Senior Vice Provost for Global Engagement and Chief International Officer, and Dr. Claudia Luccineri, the Dean at Dell Med, for their support. And also, I want to say thanks to Dr. Tim Mercer, Chief of the Global Health Division at Dell Med. Thank you for being part of this landmarking symposium at UT Austin School of Nursing. Who came?
Thank you, Dean Im. Now I invite one of our esteemed guests, Dr. Sonia Feigenbaum, Senior Vice Provost for Global Engagement and Chief International Officer, to say a few words on behalf of Texas Global.
Thank you so much. On behalf of the University of Texas at Austin and Texas Global, it is my distinct pleasure and honor to welcome you to the second annual symposium, State of Nursing Science Endowed Lectureship Symposium. Today's symposium, themed Global Leadership in Nursing and Health, brings together an extraordinary group of scholars, practitioners, and thought leaders from across the globe. We are privileged to host distinguished speakers from South Korea, 안녕하세요, Japan, Taiwan, Thailand, Kenya, and the United States, each of whom brings a wealth of experience and insight to the evolving landscape of nursing, science, and global health. International engagement is central to the University of Texas at Austin's identity as a world-class institution. With over 8,000 international students and scholars, 4,600 students learning, interning, or researching abroad annually, and 600,000 alumni living in 176 countries worldwide, UT Austin is truly a global institution. Our faculty, students, and alumni are driving impact across disciplines from engineering and public policy to medicine and global health, positioning UT as a hub for transformative ideas and solutions and embodying our university's motto, "What starts here changes the world." Today's gathering stands as a powerful reflection of UT Austin's enduring commitment to advancing interdisciplinary collaboration, global engagement, and innovation in healthcare. The event is supported by our Campus Internationalization Fund, Event Fund, which fosters high-impact cross-institutional global engagement activities on UT's campus. We are really honored to be able to contribute to this meaningful endeavor and to the vibrant exchange of ideas it represents. I commend Dean Unok Im and the entire organizing team for curating such a rich and impactful program. As we explore topics ranging from maternal health and infectious disease to digital health and geriatric care, I encourage you to share insights, ask questions, and build connections that transcend borders. The challenges we face in healthcare are global, and so must be our solutions. In these globally turbulent times, the role of academia is more critical than ever. We must continue to train leaders, practitioners in every field and foster cross-border partnerships that advance global health. Our collective efforts will be essential in shaping a healthier, more equitable future. To all the faculty, healthcare practitioners, and scholars in attendance, thank you for your leadership in global healthcare, education, and research. Thank you for being here. Thank you for taking the step to being on our campus, whether you're joining in person or you're joining us virtually. Let's make this day of learning, inspiration, and shared purpose. Thank you.
Thank you, Dr. Feigenbaum. We now invite our next esteemed guest, Dr. Tim Mercer, Chief of the Division of Global Health at Dell Medical School, to share a few words.
Thank you so much. Good morning. My name's Tim Mercer. I'm the Chief of the Division of Global Health at the University of Texas at Austin Dell Medical School. And on behalf of Dell Med, I'm honored to be here this morning to give a few opening remarks at the second annual State of Nursing Science Endowed Lectureship Symposium on Global Leadership in Nursing and Health. First, I would like to thank Dr. Feigenbaum, Senior Vice Provost for Global Engagement at Texas Global, and Dean Im from the UT School of Nursing for inviting me here today, and a big thank you and kudos to you, Dean Im, and your team for hosting such an important event. And on behalf of Dell Medical School and the broader UT Austin global community, I'd like to extend a big Texas welcome to all of our esteemed guests and speakers. It seems that there may be no better time in history for us to come together as a global health community. Global pandemics know no bounds. People are moving across borders and throughout the world at increasing rates, and the dissemination and consumption of information and ideas is truly transnational. Pregnant mothers or older adults with diabetes from the US, Mexico, Kenya, Korea, Thailand, Singapore, Taiwan, and Japan have more in common than they do apart, and they need our collective solutions. And our nursing and medical students will benefit from shared learning models and both cross-sectoral and transnational approaches to teaching and scholarship. Our faculty will speed the pace of discovery by conducting research that is highly collaborative, and our frontline health workforce, nurses and doctors alike, will take better care of patients by leveraging the best approaches and lessons learned from across the world. We are always better together. Dell Medical School and the UT Austin School of Nursing are proud to be global leaders in nursing, medicine, and health, and we are humbled to be joined here today by such esteemed global leaders from across the globe. We are delighted to create a forum for the exchange of knowledge and ideas in global health. There is inherent power in academia generally and in schools of health sciences specifically to be a force for good in the world, to bring to bear our rich human and intellectual capital on the health of the communities we serve. Through our joint missions of clinical care, education, and research, we can lead in achieving justice and health for people worldwide. Thank you again, and best wishes on what will surely be a thoughtful and inspiring symposium and an impactful day for global health. Thank you.
Thank you, Dr. Mercer. We ask that you and Dr. Feigenbaum come up for a quick photo with Dean Im. Okay, so before we begin our symposium, I would like to recognize the recent loss of the UT Austin School of Nursing's inaugural dean and beloved nursing icon, Dean Emerita Billy J. Brown. Our many accomplishments and those of our alumni would not be possible without her leadership. During our school's early years, Dean Brown navigated around issues associated with limited fiscal and material resources while continually striving to achieve excellence in nursing education, research, and public service. We take comfort in knowing her legacy of kindness, generosity of spirit, and the school's globally renowned reputation that she helped to build will endure. Join me in a moment of silence to reflect and honor the memory of Dean Emerita Billy J. Brown. Thank you. Okay, so now for some housekeeping items for our attendees. Please note that we will not have Q&A sessions after each of the presentations, but instead we will be having a moderated Q&A panel with the speakers at the end of our program. So please plan to submit your questions at the check-in table or in our YouTube live chat during breaks after every presentation. And for those of you interested in obtaining continuing nursing education credits, both in-person and virtual, we will display a web link and QR code after every presentation where you can submit your CNE survey and receive your certificate. If you happen to miss one of our CNE links, no worries. We will be sending all the CNE survey links to registered attendees at the conclusion of our symposium. Please fill out one unique CNE survey for each of the presenters and be sure to download your CNE certificate before closing the survey webpage. Okay, so now without further delay, I'm excited to introduce the Laverne Gelman Lecture in Nursing presented by Dr. Michael Chung. Dr. Michael Chung is the Director of Treatment, Research, and Expert Education at Emory University, also known as TREE. In addition, Dr. Chung is the Associate Director of Emory University's Global Health Institute, a professor in the Emory University School of Medicine, and affiliate professor in the Rollins School of Public Health at the University of Washington. Dr. Chung spent nearly 20 years living in Kenya and Vietnam conducting research, teaching medicine, building health systems, and treating patients before returning to America. He co-founded the Coptic Hope Center for Infectious Diseases, one of the largest single-site HIV treatment clinics in Kenya, and chaired the Department of Medicine at Aga Khan University in East Africa. Dr. Chung received his MD from the University of Chicago, Pritzker School of Medicine, PhD from Ghent University, and MPH from Harvard T.H. Chan School of Public Health. He is board certified in internal medicine and infectious diseases and is a fellow of the Royal College of Physicians of Edinburgh. Please join me in welcoming Dr. Michael Chung.
Thank you. Thank you very much for this opportunity to speak to you, and thank you so much to Dean Im. And it's wonderful to be here at the University of Texas and come to Austin from Atlanta. It's my first time here, and already I'm very impressed and looking forward to visiting some places I've only read about, including Franklin Barbecue, which I saw along the line here. I was like, wow, this is so cool. Let me first give an outline of what I'll talk about today. I'll give an introduction first, introduce myself. You heard a little bit about myself, and give the setting in which I'm going to make an argument that nursing is very important, if not essential, in global health and global health research. And in giving the setting, also now just focus on a couple of diseases in which to make my point. And the point that I'll make is that the importance of nursing is found in three primary areas in low and middle income countries: in care, in impact, in public health interventions, and in leadership. And then from there, then conclude and hopefully be able to answer any questions, but maybe at the end of the program. So let me start first in an introduction by, even though maybe talking about something dry as research in global health, but also introduce to you a beautiful country of Kenya that I have lived in for a number of years by showing some photos of being on safari, so that hopefully you'll be inspired to go on safari yourself. So to remember Kenya and East Africa as not just a place to do research, but a place to visit. So let me first start by making my argument that I'll make throughout this talk of why nursing is so important in global health. And it is these three areas, in care, in impact, and in leadership, that I'm going to talk about. And first in care, I think for many of us who have lived overseas and worked in these settings, it is obvious to us, and hopefully it will be obvious to you by the end of this talk, how essential nursing is in the delivery of healthcare. It delivers the bulk of healthcare in low middle income countries, and particularly in rural areas. And because of that, is so essential in now being able to formulate any sort of public health impact. So in any research that I've been doing, and I'll give several examples, actually involving nurses in the type of interventions we do is essential if we're going to make sure that we make any impact. And because then nurses are so involved in every aspect of what we do, whether it's delivering care, whether it's implementing the programs or delivering the interventions, they serve as leaders in our programs, and I hope to convince you to join us in some of the research that we do. So as you heard a bit about, I'm a professor. My home base is at Emory University in Atlanta. Joint appointments in the Department of Global Health and Epidemiology in the School of Public Health because of the work that I've done. I've been serving as the Associate Director in the Emory Global Health Institute, where I lead a program called TREE that you heard about, or Treatment, Research, and Expert Education. This program I founded a number of years ago when I was first in Kenya, really as sort of an overarching infrastructure to do the work that we've been doing. Its mission is to address health inequities, and currently being based out of Atlanta, we deal with that at Grady Hospital where I work now. But typically in what we've done in Kenya is now follow what may be recognizable to you as this tripartite academic mission of treatment, research, and education. And so in these settings, we have been providing treatment directly by treating HIV positive patients. And we've been actually asking questions that are directly relevant to improving care for people living with HIV in these settings. And then as part of what we do is building capacity to do not just treatment, but to actually conduct research. And this is all very important and serves each other in what we do, and I'll give examples of that throughout this talk. And for me, I was born and raised in America. Maybe I was thinking now that I'm in Longhorn country, I shouldn't mention that I grew up in Ohio, but that's where I grew up. Maybe I shouldn't mention that my son is at Michigan, and I'm from Georgia now, but I realized that maybe this is my background. But even as I received my education in the US, I had moved overseas as part of my infectious diseases fellowship in Seattle at University of Washington, and was lucky enough to be based overseas. 8 years in Nairobi before moving to Vietnam for 3 years, and then coming back to Kenya for another 8 years, for almost 20 years before we returned due to the pandemic in 2020. And during that time, practiced medicine, saw patients, conducted research, and led local health organizations like the Aga Khan University Department of Medicine that you heard about. And I spent that with my family. So you see pictures of me with my friend James Chiari, who's now at WHO, but including my son Adrian, who really sees himself, despite his Korean-American background, as Kenyan first and foremost. So what is the setting that I'm going to make this argument about the importance of nursing in global health research? Well, obviously it's going to be Kenya. I could have talked about Vietnam too, but Kenya is where I've spent most of my time. And you see here now it's in Eastern Africa, in blue, bordering the Indian Ocean there. And it has a population of over 50 million people, and is wildly and beautifully diverse. It has many different tribes from all over Africa. But you see now it bordering the Middle East to the north, and then India to the east, has many, many different other countries who have settled there, including Europeans, like the British. So it has many different cultural influences, which makes it a fascinating place to live. It is the majority Christian there, but it has a sizable Muslim population of over 10%. At the same time, while it has grown and developed quite a lot over the last 20 years, it still remains a lower middle income country, which means that typically per individual maybe earns between only $1,000 to $4,500 a year. So on the Human Development Index, it is only 143 out of 193. It's still towards the lower end of the development index, which really then points to the issues of access to health and health care. The health systems in Kenya, because of its setup, then tries to provide a universal health coverage through what it calls now SHA, or the Social Health Authority, which is its insurance. And it does it through multiple different levels, starting at the basic level of the community, and then now building its way up to primary care facilities, county hospitals, and then lastly in cities like Nairobi, where you have national referral hospitals, like Kenyatta National Hospital, where I continue to work and do collaboration work. It has about 190,000 healthcare workers, of whom the majority, almost 60%, are nurses. And at the same time, though, is not enough healthcare workers. It's less than 70% of the Sustainable Development Goals. It needs a lot more healthcare workers and a lot more nurses to actually meet all the needs. And most of these nurses, over 80%, work in public sector, in public hospitals or public clinics, and that's where the majority of Kenyans receive their care, particularly in rural areas. So with that, then, I hope you're starting to see that nursing in Kenya really reflects the most critical cadre of healthcare workers, and it delivers primary care, really, in rural areas and in these public sectors. You just don't have enough doctors, and you have nurses actually delivering the care, and I'll give you several examples of that. And unfortunately, there are still not enough nurses. There's chronic understaffing with a nurse-to-population density of only 16 per 100,000 people. So in as much as nurses are still going through training, and it's a very popular career to go into, you can earn a diploma from the medical training college or go to university for 4 years. At the same time, as many of you probably know, many of the nurses then come and leave the country. And so we always have this understaffing in Kenya as they come to America or go to the UK or Europe. So what diseases can I focus on? Well, I'm going to be a little bit biased. I'm an infectious diseases doctor, so I'm going to talk about infectious diseases. And at the same time, not let me put all these infections or diseases on you in making this argument. I'm just going to focus on 2 infections, if you will, and 2 viruses. One is HIV, which causes AIDS, which many of you are familiar with, and many of you are familiar also with human papillomavirus, or HPV. And I'll talk about HPV particularly as it now causes cervical cancer worldwide. And so these 2 diseases are where I'll make my argument. So let me describe why then HIV is an argument for Kenya and East Africa. Well, in this map of prevalence of HIV worldwide, where you see now greater prevalence of disease painted in darker red, you really see it now in Africa, right? So in southern Eastern Africa, you see the darkest shades of red and orange. And you see now Kenya in East Africa, they're really having higher prevalence of disease when compared worldwide. So the prevalence of disease nationally is, at this point, lower than it has been. It is 3%. It is higher in certain areas of Kenya, like in Western Kenya, where it can get upwards of 15 to 20% in certain areas. But 3% is still a lot. With 50 million people, you have absolute numbers of over 1 million people who are living with HIV. So 1.4 million people are living with HIV in a setting now where I think in America we really see this disease really in the men who have sex with men community or among IV drug use. But in Kenya, it's really a heterosexually transmitted disease. And so the majority of people who are living with HIV are women. So 60% of people living with HIV are women. And fortunately, over the last 20 years, given the work that I'll describe and given the work that Dr. Mercer has done at AMPATH and MOI, over 90% are on antiretroviral therapy, or ART as we call it, which has been a wonderful success story. But unfortunately, there's still ways to go. And even just last year, we still have this disease that is expanding. Over 17,000 were newly infected just in the last year, and over 20,000 still die of AIDS-related diseases. So now let me pivot from HIV to HPV and now show you a blue map of what HPV causes. And this is now cervical cancer. And you'll see now in blue, higher incidence of HPV. And again, I hope you'll recognize that it really affects low and middle income countries, like you saw with HIV, with South America, Southeast Asia, particularly South Asia affected. But you see also now Africa really now in darker blue, where a higher incidence of diseases there. Really in southern and eastern Africa is where now you have the highest incidences of cervical cancer. And yes, in Kenya, then what it means is that it is the second highest cause of cancer. And sadly, we don't see it in America much because we have prevention, we have screening, we have pap smears here. But in Kenya, even with this preventable disease, less than half of the women who are eligible for screening have ever been screened in their lifetime. So even just screening just once, less than half have ever been screened even just once for cervical cancer, which then you can see now why we're detecting so much fatality from cervical cancer. And even now with the vaccine, we have an HPV vaccine which should prevent this. Less than half of girls less than 15 years who could receive the vaccination have received it at all. So ways to go there for cervical cancer and HPV. So now having set now perhaps where we're talking about and what diseases we're talking about, let me make the argument of why nursing is so important. And so as you remember now, the first point that I want to make is around the delivery of care. And let me give an example of the Coptic Hope Center for Infectious Diseases, where I worked for a number of years and continue to do research. And our story started 20 years ago now with a woman named Grace Chiang, who has given her permission to share her photo here, who at the time was a community health worker in one of our research projects and was dying of AIDS and didn't have access to antiretroviral therapy. And me, as a fellow at the University of Washington at the time, started to ask around among students and residents if we could just raise money to now buy medications for her. So we started to raise hundreds of dollars here and there and came up with like $1,000 at first. And we said, okay, what can we do with $1,000? And we realized that very quickly, if we bought brand name medications at the time, we would run out within 2 months. So we started to look around in Nairobi and found a pharmacy that, wonderfully enough, was importing generic ART or antiretroviral therapy from India at the time. And now, instead of now $1,000 lasting only 2 months, we could stretch it out for a whole year for Grace. So we started to now buy these ART at this pharmacy and started to raise more money and started to put now more and more people on antiretroviral therapy with now medications that only cost a couple, maybe $100 a month. And so I would now go to this pharmacy and fill up my car with all this ART and then drive it away. And then the pharmacy was located at the Coptic Hospital, which was starting wondering, what is this Korean American guy doing coming here, buying all our drugs and going away? They thought maybe I was selling it. And the Coptic Hospital's pharmacy that was doing this was amazing. And Coptic Hospital was set up by the Coptic Christian missionaries from Alexandria, Egypt. And they were there had been there for a number of years already. And when the HIV epidemic really hit Kenya, they were noticing that the members of their congregation were dying of AIDS. So they actually, at a time, to their credit, when most Kenyan churches, sadly, were excommunicating their members for having HIV, they went out of their way to actually find antiretrovirals to actually treat their members. And so they found those drugs in India and started importing them. But at the same time, they didn't know how to treat HIV. So we started talking to each other, and I said, well, this is great. I know how to treat HIV, and you can import these drugs. Why don't we work together? So this relationship then started where in 2 rooms that you pictured here, that's not much larger than a walk-in closet, we started to see 1 or 2 patients a day and brought a nurse that now was stationed in front of this Hope Clinic, as we called it, to now start to see patients and to dispense antiretroviral medications. And then at this time, now in 2004, the President's Emergency Plan for AIDS Relief came along, which was an endeavor under George W. Bush to now provide funding to buy antiretrovirals. So kind of on a lark, because Coptic Hospital had never done this before, we thought, well, why don't we apply and try to get this money? So with the University of Washington and with Coptic Hospital, we applied for $200,000 to put 20 people on antiretrovirals, and they said, this is fantastic, why don't you go? But it ended up that we put on 200 people with antiretrovirals. So then they started to giving us more and more funding. And we, long story short, over the last 20 years, have built now from this closet a 7-story building that has seen over 25,000 patients and put them on antiretroviral medications, and is one of the largest single-site treatment centers for HIV, I think rivaled only by Dr. Mercer's work at AMPATH in Moy, which also has a large program there. And Coptic at this point is the center of excellence for HIV care, and it's grown far beyond what I've been able to share with them, and now oversee a faith-based network of over 25 clinics across Nairobi County, delivering care and seeing tens of thousands of patients and delivering care to thousands of patients per month. So it's a great success story of now what has happened. And I want to make the argument that that nurse that you saw at the beginning was critical to that. The funny thing that happened to us, even as we started our first patients that were seen, is now that they didn't know who the pharmacist was. They didn't even know who I was, but they knew who the nurse was. And the nurse, because we were at this Hope Clinic, was called Mama Hope. So Mama Hope was actually the most important person to actually now retain the patients in care, explain the HIV disease to them, and convince them to keep coming back and to have faith in the system to now actually take the antiretrovirals. This now example is not our own, even at Coptic, but in comprehensive care clinics across Kenya, which are the HIV clinics, we have seen time and time again where nurses play a fundamental role in delivery of care in such a way that now in the last 5 to 10 years, there has been this recognition that we have to do task shifting. We can't depend on clinical officers or doctors to deliver this care. We need to have nurses do this, particularly in rural areas in the public sector. These tasks have shifted to now nurses initiating antiretroviral therapy because they're so key in retaining patients in care. So now let me shift now from the city now to the farmlands and make the argument around HPV in the same way. So I'm going to take you out of Nairobi and take you now to a beautiful town called Nyeri, which is near Mount Kenya and is in high elevation. And what I'll do is say that next time you go to a specialty coffee shop, and I see many throughout Austin, go look for Kenyan coffee, because some of the best coffee in the world, and yes, I'm biased, but it's true, comes from Kenya. So not only Ethiopia, but Kenya has some of the best coffee. And it's because of the high elevation of now the farms. And what we have found out there is that the farmers who go out there also have their own health issues. And because they're in their rural areas, have challenges with access to health care, whether it's now the pesticide use, whether it's snakes, whether it's injuries now from working in the mills. They also now have issues related to cancer. So now me coming out of the University of Washington, originally being based in Seattle, which is the home of Starbucks, I now got to know some of the coffee importers that were there in Seattle, and one was named Atlas Coffee Importer. And we got to talking, and they said, you know, we really want to support, and we want to close this loop of now making sure that our consumers that are in these cafes can support the coffee farmers directly. Can you help us? I was like, yeah, that's a great idea. So we cooked up this pennies per pound scheme where now, just for a penny that was added on to every coffee that people would buy with coffee from Atlas, we would now funnel that into a cervical cancer screening program for the female coffee farmers in Nyeri, and was managed to now start a program where, using our tree staff, we would go out to Nyeri every couple of months or so and start to educate the farmers on cervical cancer, on the risks of it, and start to screen and treat them for cervical cancer with funding from Atlas, but then started now this collaboration while I was at Aga Khan University to now expand this program and utilize their infrastructure, including their mobile clinic. So we were able to now do this much more frequently in this partnership that, again, closed the loop with Atlas, with University of Washington, with Aga Khan University to help people help women get screened and treated for cervical cancer. And so where does nurses play a role for HPV infection or for cervical cancer? Well, in addition to vaccinating young girls for HPV, nurses, again, are fundamental to screen and treat women for cervical cancer. So unlike for here, maybe where we get pap smears that now have to be sent to a lab and have a cytotechnologist read it, and then now you have to come and maybe a gynecologist has to do a cone biopsy or do some sort of excisional procedure, nurses do all of that here. So nurses can identify precancerous lesions through now just using vinegar to look for aceto-white lesions, now in a process called visual inspection with acetic acid, or VIA. And now we have HPV testing, which they can do, either doing that test with a pelvic exam or having the women do a self-collection for that. But nurses can and have been identifying women for cervical cancer and using now a battery-operated machine called a thermal ablator that you see here in white, can now actually treat women for cervical cancer too, and have been doing that with what we have called cryotherapy in the past by freezing it. But now with this battery-operated machine, which can be recharged using solar power, now they are treating women, and you can see now this is the example of having used heat on the face of the cervix to now treat these precancerous lesions. So now, literally one-stop shopping, literally what is called a screen and treat approach. Nurses are fundamental in now making a difference for cervical cancer. So let me now move on from care to impact, and impact in the realm of now studies and interventions. So now you see now where nurses are so important in the delivery of care for this disease, for HIV and HPV. So when we are now going to ask research questions, whether it's an HIV or whether it's an HPV, what do we now want to do to sort of make an impact? Well, the obvious thing is now to work with nurses. So one of the questions that was there at the beginning with HIV is now how to improve adherence to antiretroviral medications. And this was now particularly at a time when we were using NNRTIs, or non-nucleoside reverse transcriptase inhibitors, which had a low barrier or threshold to resistance. So just one mutation, K103N mutation, could blow the whole class and really risk now resistance, viral failure, and then subsequently with a high viral load, infection of the CD4 counts, which would lead to immunological failure, and ultimately. Can we help now Mama Hope improve adherence to antiretroviral therapy and the clinical outcomes of suppressing viral load and preventing death? Well, we did this study way back in 2008 or so, at a time when still the permeation of now cell phones was very high. So, and thought that, well, maybe text messaging, and this is a time when we didn't really have cell phones, maybe text messaging, and this is now what we learned from the nurses. How can they link with their patients better is what we heard. And we said, yeah, why don't we try a text messaging device now, knowing that many of the patients or their friends and family had also cell phones. Can nurses now text message with their patients? And would that make a difference in staying adherent to medication and improve their viral load? So long story short, because there's a lot of things I want to cover, in the study that we did with Professor Rich Lester at the University of British Columbia and in collaboration with the University of Nairobi, we published a study that was performed at the Coptic Hope Center where we saw almost a 20% improvement in adherence, or 20% reduction in poor adherence when we actually used this text messaging intervention, as well as a biomedical outcome of improved viral suppression, which was fantastic, and even now is very difficult to see. There are very few behavioral interventions that will see a biomedical outcome, and this is one of the few times that we saw this. And when we went back to say and to talk to people, we were wondering, now what actually made a difference in all of this? Well, what we heard is that really what we did is not remind people to take their medications, but we actually had a situation we were asking, the nurses were asking just literally, how are you? They didn't ask, did you take the medication? They asked, how are you? And if the person said good, they didn't talk to them. But if they said bad or didn't reply, then we actually reached out again and we said, okay, how can we help you? What should we do? It actually wasn't about the medications. But in doing that, the patients literally said, someone cared about me. The nurses cared about me. And that's now what improved their adherence. So research question for cervical cancer. Similarly, we do very good in screening, but we're very bad in actually following them up and getting them treated. We have too much loss to follow up. So now we've advanced ourselves to now advance to an mHealth app to say, hey, how can we actually connect screen-positive women to now treatment with that thermal ablation machine that you saw? And in partnership with Professor Karen Yates at Queen's University in Canada and with Kenyatta National Hospital and Kenya Medical Research Institute in Nairobi, we are now utilizing this mHealth app called WEMA to actually help nurses track their patients now to see what results they had and to communicate with their patients through text messaging what result it is, as well as also take photos so that they can get feedback on the quality and what the disease is and teach their patients what they're seeing to get the buy-in from the patients. So we're conducting that study now that's supported by NCI in a U54 and U01 grant and is a fantastic study that we think will make a big difference. So finally, let me talk about leadership. And let me do that in the context of HIV and HPV that I have said separately, but let me bring them together because they are overlapping disease burdens. So even as you see the darkest red and the darkest blue, they're happening in the same areas. And it means now actually HIV and HPV synergize in very bad ways. As you can imagine, with the immune compromise with HIV, you have now HPV infection that's even greater. And you actually have progression of HPV that's even greater, so that women living with HIV have a much greater incidence and prevalence of cervical cancer. And NCI, the National Cancer Institute, has recognized this by now forming what is called Cascade, or a clinical trials network for women living with HIV, to now run pragmatic clinical trials to examine now what now optimization can we do for screening and treatment for women living with HIV. And our Hope Center is now one of 9 research bases that is implementing these clinical trials even as we speak. And so this is an example of now what we're doing even now with the University of Washington as Emory University, where I sit now, of using that thermal ablation machine and saying, well, can we play with the probes that are at the end of this to now say, well, one probe that may be flat versus one probe that may be a nipple can do better than the other. And so in doing now, you see a clinical trial profile here and you see a timeline here. We're going through all the motions now to start up this study, including now applying for IRB approval, getting the people trained and recruiting, and now following up these patients. Doing all this work takes quite a bit of effort and takes leadership on the ground. And so I want to introduce to you one of our star study coordinators, Judy Lucaritu, who is a nurse who is now based there and is a co-investigator on our study and who is doing all that work. She is now doing the interventions that you see here. She has been practicing in Nyeri doing the cryotherapy you see here, but leading the staff in managing now, overseeing now what has to be done to make this study possible. And without her, none of this could happen. And without her input to understand how we should look at these probes, none of this can happen. Again, because she's now real-time doing these things, we're able to get her input at multiple different levels to do this work. So as leaders, what we're seeing is that nurses play a critical role in leadership as co-investigators, but also as principal investigators in formulating our questions and answering this, and as coordinators on the ground actually implementing these studies. So let me conclude here. First, my son did survive this encounter with the rhino. I don't recommend getting this close. But in summary, I hope that you understand the importance of HIV and HPV in our setting and that there are dual overlapping burdens of disease in places like Africa, and that nurses play a critical role in addressing these diseases in low middle income countries, and that if we're going to find any sort of impact, our research questions that are going to be relevant to this setting now needs to understand how better to support nurses to actually do that work and connect with patients. And we're going to then make a difference in that way. And we need more nurses to sort of be involved, like you and on the ground in Kenya, to be involved in this research and to help us understand what to do better. And if we do that, we're going to make a much bigger impact. And then finally, I hopefully you did see all the photos and will take advantage of this opportunity to go on safari to East Africa and meet all the beautiful people and the animals and places that I've been to. So I have to thank many different institutions that have been a part of what continues to be a wonderful research safari, including NCI and NIAID. Thank you for this opportunity to speak with you, and I'm happy to answer, maybe not questions now, but after the program. So thank you very much.
Thank you so much, Dr. Chung, for your inspiring presentation. I learned so much, and I am so inspired by all the wonderful stories that you shared. At this time, I'd like to invite Dean Im and Dr. Chung again for special announcement.
Thank you for your insightful presentation. And I present this plaque as a token of our appreciation on behalf of the UT Austin School of Nursing. Thank you.
Yes. Thank you.
Great. So this wraps up our first presentation, and we will have a brief intermission before beginning our next presentation at 9:45. Again, please use the QR code or link to complete the form for the CNE credit, and feel free to enjoy some refreshments outside. And don't forget to submit your questions for Dr. Chung to our check-in table or in our YouTube live chat. So feel free to take a break, and we'll be back at 9:45. Everyone, please be seated for our next presentation. It is my great honor to introduce the George and Diana Sharp Perinatal Lecture Presenter, Dr. Haewon Kim. She's in the front with us already. Dr. Kim is a professor in the College of Nursing at Seoul National University, where she previously served as dean, and she has held key positions at the Catholic Kwangdong University and Seoul National University, including Director of the Department of Nursing and Director of Research Institutes of Nursing Science, respectively. She earned her BS, MS, and PhD in nursing from Seoul National University and completed postdoctoral training at the University of Michigan and Catholic University of Leuven in Leuven, Belgium. Dr. Kim is a leading scholar in women's health, reproductive health, and nursing science, with extensive publications in international journals. She has served as editor-in-chief of the Journal of Korean Academy of Nursing and Perspectives in Nursing Science, and currently sits on the editorial board of the Journal of Korean Medical Science. Dr. Kim also serves as vice president of the Korean Association of Sexology and president of Korean Academy of Women's Health Nursing. Dr. Kim's work continues to shape nursing education, research, and policy in Korea and beyond. Please join me in welcoming Dr. Haewon Kim.
Can you hear me well? Thank you for my introduction, Linda. I'm Haewon Kim from South Korea. Good morning, everyone. Thank you for this opportunity to share Korea's journey in women's health nursing. Today, I'll talk about how women's health nursing in Korea has demonstrated global leadership. My presentation is organized into 4 parts. First part is the context and framework surrounding nursing leadership in the current. Then my main contents are that leadership led to advancing antenatal and postnatal care in the community, then global exchange and partnership in maternity nursing, and the contribution to knowledge development in women's nursing. And in the final part, with current issues and future direction, I will make. So, as a context and framework for discussing today's topic, I'm so curious what could be the nature of nursing when we are demonstrating global leadership. The answer could be like this. The 4 concepts, I want to emphasize that we are central to achieving sustainable developmental goal, SDG. And then our mandatory principle is to relate health equity. And the third is as a framework, social determinant of health. This is directly influence our health outcome, and the current trend in healthcare sector, the growing importance of interprofessional collaboration. Thus, taken together, nursing advances SDG by promoting equity and addressing social determinant of health and engaging in interprofessional collaboration. That could be my ultimate goal in entire my presentation. Well, from the recent study, the right side means especially when women are leaders, they can have a very powerful outcome, such as financial stability up to 88 person improvement and engagement with ethical initiative and innovation matter and the health outcome, it is very natural. Even the changing the organizational culture and climate. Most important thing should be the women leader. They can influence the other women's career and aspiration of other women. So that's why I want to emphasize when we are discussing women health nursing leadership, the women's role are so important. On the left side, as you can see, we know already about much of our healthcare workforce are mainly the nurses, nursing, and nearly 90% nurses and midwifery workforce, but we are just holding 25% of the leadership role. So this means the gap in this leadership position, we have to promote it and we reduce the gap. And during the preparation, my topic, I have a question, the relationship between what's the differences between global leadership of nursing and the global leadership in women's health nursing. My answer is their relationship is very reciprocal, mutually dependent each other. The left side means the global leadership of nursing, which provide an policy and organizational framework for our collaboration. Then the right side, the part of global leadership of women's health nursing, they can implement its global vision into concrete our practice field. So that's why I can say the relationships is very close. They are not separable. So I'm going to tell you about our main content. So that is how Korea has advanced our nursing practice, especially focusing on antenatal and postnatal care in the community level. While in the afternoon, in the aspect of the clinical nursing practice in maternity and women's health could be raised by Dr. Kim Jung-im. Just I want to focusing on the community level. So the first is I want to show you our home visiting program, which is nurse-led program, and it is now nationwide. So we called it ECHCP, Early Childhood Healthcare Project. In 2020, a pilot project was initiated, and 78 municipalities are working together. The point is, the very specially trained nurses, they can collaborate with other healthcare team. Consists of the basic visit and the continuous visit. So during the pregnancy and after birth, for high-risk family, we can provide a continuous visit. Their service related to maternal care and infant development and even emotional support, and when necessary, we can link community services and resources. In the program, the participants were very satisfactory. So the score is 9.3 out of 10 score. The research has shown its efficacy also. They improved parenting capacity and increasing child development, also emotional stability. I can say it is related to the reducing health inequality. So in last year, the government, Ministry of Health and Welfare, recognized the service contributions the two women's health nursing professor. The next, which is a commissioned project in Seoul, they called it Healthy Baby First Step, launched in 2013. Actually, it is based on the Australian model, which is sustained home visiting. In the project, Seoul National University, my university, College of Nursing, and with Seoul National University College of Medicine and other nurses and other graduating students, they can together in the project. Also proven to improve maternal health and child health and increasing parental capacity also. Also, this service is also consists of universal visit for all family, and when necessary, continuous visit for family with at high risk or special need. In the program, I can say the core program is the tailored parent group education, such as breastfeeding or maternal stress management and infant development, so on. Also, this program in Seoul, they have shown improving parental capacity and reduce postpartum depression and enhancing healthcare indicator also. So I can say it could be potential role model in the Asia Pacific region to other country. I think it is one example of the successful IPC in ANC and PNC in the community. In the framework and the context, I emphasized already on SDG achievement. So these nurses' activity in the community are very close to achieving SDG Goal 3 on maternal and newborn health, Goal 5 on promoting women's health rights, and Goal 10, enhancing health equity. The second nurse-led postpartum care I could tell you, which is a postpartum care center in Korea. This is very unique. Korea has institutionalized postpartum care. That means after birth in the hospital, when they discharge the hospital, they are not going to home. They are going to directly postpartum care center. So almost 85% of mothers, they are using PCC. So there are so many. As of 2023, 456 postpartum care centers in Korea. Among them, almost 20 is a public center, the small proportion. So that's why there is a very significant differences in cost. So almost average 2 weeks using the fee in private center is almost double, more than double than public center. The employment in postpartum care center, it should be the critical person is also the nurse. Nurse would be always a health manager and other staff to support their care and the other support in postpartum care. Meanwhile, the Korean-style postpartum care can be seen in other countries in abroad. For example, in China and in El Salvador. So the map like this. In China, I wrote the cities, Beijing and Wuxi, and the map of El Salvador. And the right side, the picture illustrates they are exercising at the postpartum period with near their baby together. So how to effectively postpartum care center in Korea could be successful. I think it is also nurses' a critical role and also proactive collaboration with other steps. And my wish and ultimately our role is to establish or propose a postpartum care standard, nursing standard, which is internationally aligned or systematic or more refined, I think. So this kind of the care in the postpartum care center could be very close to SDG 3 on improving maternal and newborn health and SDG 5 on promoting women's health rights. And third one is home visiting service for multicultural family or married immigrant women in Korea. Actually, the Korea has become a multicultural society. As you can see, among the foreign wives in Korea, still the large proportion from Vietnam and followed by China and Thailand. To visit them, the specialized nurses are also important. They are working together also under the government influence and collaboration with multicultural family support center and health center also. They can support such as integrated prenatal education, sometimes with differences of their language basis. So we can consider that. And breastfeeding, nutrition, and emotion support, so on. I think this culturally adapt home visiting model can ensure that quality of community-based agency and PNC, and also contributing to global health improvement. So this is also related to achieve SDG 5 and SDG 10, gender equality and reducing inequality. Now, I can move on the second content that is global partnership and exchanges. In the middle, this is the logo of my school. And the others are some the governmental agencies, Koika and Coffee, and in the Seoul National University, the College of Medicine, they are learning a very specific fellowship program, such as Lee Jong-uk. So, in the collaboration and in the exchange, I can say in the level of academic society, Korean Society of Women Health Nursing, it is also 30 years old, more than. During the time, we have been promoting academic activities domestically and internationally, and 450 scholars and researchers are part of our society. We provide new faculty mentoring, and we call it Level Up, and also capacity and leadership building, and not only within Korea, but also we have an opportunity to do in Vietnam at Hue University under the former president of our society, Dr. Kim Jung-im. Second, it's just a little bit, my experience I want to introduce a little bit. As I said earlier, many years have been served as an advisory committee member in International Health and Medical Training Program in Seoul National University. And 1 year mentoring experience I have. So one midwife from Laos, I was supporting through Lee Jung Fellowship Program. What was my learning through the mentoring? I can say both we are fostering mutual understanding, mutual respect, and we are getting more strong nursing identity, the bonding. So it could be more powerful to ourselves. So ourselves are empowering as a result. And the lower part, I have also engaged in research collaboration. Was also a very meaningful experience for me, but especially the topic was nursing leaders' characteristics in our region, and also the mentoring related topic. That's why it was very meaningful for me. Some of the authors are here, including Dean and Professor Imuno and other also from Japan. Well, the next is the level of within educational institution. The nursing schools are very actively collaborating with our Korean government agency, KOICA, through their MCA or ODA program. So as a representative case, I can take an example, my college. A few years ago, we did the collaboration, especially to strengthen MCH and family planning capacity in the region of Tigray in Ethiopia, and two other universities also. They are actively engaging in the project in Laos or in Ghana, Africa region. So through the experience from ODA, especially maternal child health project, we have shown much our competencies and role from the education capacity or transferring high-risk maternal and newborn care, and how to counsel and how to educate family planning. And sometimes we can share directly our experience. It was a key role in transferring our Korean model to others. And also sometimes we can improve their working environment and service accessibility. So this, our collaboration through the ODA project could be reaching at SDG 3 on good health and well-being, and other SDG 5 and 10 and 17, which is related to international partnership. Now, I move to the third part. This is a contribution to knowledge development in our field. This is a cover of our official journal. So let me begin with the role of our nursing journal, Women's Health Nursing. Since 2024, we called it just Women's Health Nursing. Prior name was Korean Journal of Women's Health Nursing for more than 10 years, but we changed its name to be more visualized and to be more better globalized. It is very actively well growing, so indexed in Scopus, PMC, and ESGI, and even in Medline. our ultimate goal is to be indexed in SCI. So this chart shows in our journal how many documents are related to Sustainable Development Goal. You can see the fluctuating the trend, but anyway, even the variability in 2021 was the peak, and again recovery in 2024. We expect more than papers related SDGs are publishing. In regard to author contribution, still South Korea has a huge contribution. So the remaining small populations from Philippines or United States and Japan are very limited. So we are welcome to submit many articles from all of you. So we are now actively struggle to disseminate our publication into the world. Second point about of the knowledge development is to data creation and utilization. We in Korea, like USA, we have a Korean NIH, KNIH. They are producing very extensive women's health data regularly. They can generate. So those data we can use in our research activity. Besides that, I want to emphasize not only that we are producing, we are creating our own data platform, such as Korean Nurses Health Study, which is KNHS. The history in 12 years ago, it was established with more than 20,000 female nurses aged 20 to 45. And last year, for refreshing age structure, more younger nurses are newly entering. So the time it was a 13th follow-up survey. As you can see, the red 2 group, this is a subgroup. This is early pregnant women. And the second is after birth. So the nurses at postpartum subcohort, they are separately being followed up. So this is a very longitudinal and the metadata on reproductive health, chronic disease, and demographic and other occupational risk also, and emotional health and women's health covering. And from the subcohort, we can analyze some maternal indicator or neonatal health outcome. I can say this database could be harmonized with other international cohorts, such as NHS in US or Australian database like this, which can enable to analyze meta or providing evidence synthesis. And also, it could be a very insightful data for identifying occupational exposure among the nurses in the Western Pacific region. This database is the very largest Asian research platform, so which is supporting SDG Goal 3 related child health, mental health, and strengthening capacity for health risk response, and SDG 5 on reproductive health and rights. The second example is some registry system registration system about for improving care of very early premature baby. So very low birth weight baby. We cover almost 80% of those population in the hospital basis. So to do that, we have to establish the nursing standardization. So to do that, the very skillful experts of maternity nursing and child health nursing, they are much contribution to do. And those are our large scale of Korean national survey, case story, or sexual or reproductive health across the female life cycle. With those data, in the nursing perspective, we can use those data to determine which is the women's health issue, whether it is critical or urgent, or to perform the nursing research activity to improve our nursing knowledge in our field. And I would like to say, even though our leadership demonstration, we have a limitation also. We remain. That could be the first one, emphasize the midwives, the matter in Korea. As you can see, our midwife group is aging and shrinking with very few new midwives are entering the field. So between 23 and 25, the number of entering midwives are 8, 12, even 9, very few. The reason is so many, but I don't like to discuss why this is happening, why the essential problem underlying background of the midwifery workforce. This is beyond my time and beyond my expert. But apparently, as you already know, we are the lowest fertility rate in Korea. And besides, in addition, almost delivery are done in hospital basis. So the midwife's role is very limited. That means without midwife, nobody have problem when they are delivering. Even though our unique situation, we try to change their midwives' capacity and how to be attractive to the younger nurse population. So that is our very long-term issue we face. And still very few number of nurses are training in the hospital. So the education system is also very outdated. But now, as a positive aspect, we are creating a very innovative nursing care environment using mobile-based breastfeeding program or AI-assisted health application. That is typically for high-risk pregnant women, but it could be applicable to other settings and to other countries or integrated with their network for caring them. Also, our mission is to foster international nursing leaders more and more, especially for low and middle-income countries. And as a nurse, we have to advocate maternal and newborn health through active participation on national or global level. as a summary, within a time, I was trying to some demonstration of our leadership, global leadership in women health nursing in Korea, in terms of nurse-led continuity care, about antenatal and postnatal care. And we are accelerating knowledge development. We are creating innovative nursing environment. As an essential part, the nursing leadership could be promoting global women health through achieving sustainable development goal, I think. It should be ongoing and it should be, it must go on. The picture illustrates how to build the future's global nursing leader. This is my favorite, illustrating the three parts are important to be a global nursing leader. The one part is advocacy. One part is active participation. One part is a professional accountability. To be a role of advocates, activism, or to be a responsible professional, now we are doing something and we have to do. So let me conclude with some words by Goethe. Knowing is not enough, we must apply. Willing is not enough, we must do. Thank you for your attention.
Thank you, Dr. Kim, for your wonderful presentation. And at this time, I'd like to invite Dean in for special announcements.
Okay. Thank you so much for sharing your great work in women's health in Korea. And this is our token of gratitude. Thank you.
Thank you, Honorable Dean and Professor In. Thank you. Thank you for your attention.
Okay, so this wraps up our second presentation, and we will have a brief intermission before beginning our next presentation at 10:45. Again, please use the QR code or link to complete the form for the CNE credit, and feel free to enjoy some snacks in the reception area outside. And also don't forget to submit your questions for Dr. Kim at the check-in desk or in the YouTube live chat. Thank you, and see you at 10:45. Hello, everyone. Please be seated for our next presentation. I'm honored to introduce the Laverne Gallman Lecture in Nursing presented by Dr. Amaporn Ratenthorne. Dr. Amaporn Ratenthorne is the Dean of Faculty of Nursing and Associate Professor in the Department of Obstetrics and Gynecological Nursing at Mahidol University in Thailand. Dr. Ratenthorne has over 4 decades of clinical, academic, and research experience, making her a leading scholar in her field and an effective leader in global health nursing. She earned her PhD in nursing from the University of California, San Francisco, and holds advanced degrees in maternal, newborn nursing, and counseling psychology. Dr. Ratenthorne's research focuses on maternal child health, labor and delivery care, and women's health issues with numerous publications in international journals. She has fostered successful research collaborations with global institutions such as the World Health Organization and is an active member of the Nurses Association of Thailand, as well as the Sigma Theta Tau International and the International Council on Women's Health Issues, among others. Dr. Ratenthorne is committed to advancing nursing education, and her leadership continues to shape maternal and reproductive health care in Thailand and beyond. Please join me in welcoming Dr. Ratenthorne.
Tell you a little bit about where I come from. I come from Mahidol University, which is named after the Princess Mahidol. And I would like to let you know that today is the memorial days of Princess Mahidol, who teach us that the successful of the knowledge is not in learning, but is application to benefit of the mankind. So this is a thing that we hold as a staff in our university. Our university have 17 faculties, 6 colleges, and 9 research institutes and 6 campus. We offer the 3 core academic areas, which include health science, science and technology, and social science and humanity. Here is our Faculty of Nursing. We have the first building on the river of Chao Phraya River, connect to the biggest hospital, university hospital called Sirirat Hospital, which is the first hospital in our country. If you have a chance, please go there, visit us, and enjoy your river views for our campus. Another campus is Saraya, at Saraya. The second picture is the new building that fortunately we received all the funding from the King Rama IX to build the building and also keep lump sum of money to support to renovate or whatever we can use. And the last one is our dormitory that we have for our students. The last year we have changed our vision. We would like to make it more clear that Faculty of Nursing Mahidol is globally recognized as the international hub at forefront of nursing education to transform healthcare and well-being of humankind. We would like to make a significant impact as a nursing profession. And today, I think we have to admit that we are living in a changing world. The world is transformed a lot after COVID-19, as well as healthcare system. So I would like to discuss how we can prepare future nurse leaders for our changing world to meet the challenge and shape healthcare system, and divided into 4 subtopics. When we're looking at the impact of changing world, the global healthcare landscape is undergoing rapid transformation, driven by aging population, chronic disease burdens and aftermath of COVID-19 pandemic. Health problems are complicated by the increase in aging population and the prevalence of comorbidity or multi-morbidity event. Healthcare has shifted from the institution focused or hospital based to a community focused approach. So we have to accept that the remote access, remote care, remote service is very, common at this time. This means that nurses have to prepare to taking care of the patient through telehealth, which may require another skill of communication. The knowledge of genomics, precision health, and precision nursing are expanding. Ongoing climate change and threat of future pandemic are still our concern. We have AI, robotic, telehealth that are truly transform our healthcare and nursing service. However, the health inequity still persists around the world. We're still facing with the global shortage of nurses, especially in lower and middle income countries. I would say this because, of course, nurses migrate to work in a better environment in the higher income country. And this means that we have to looking at the traditional fee-for-service model that are volume-based care, which often incentivize a high volume of procedure and appointment, regardless of necessity or impact on patient health outcome. It focuses more on quantity rather than quality and did not concern much about health outcome, leading to fragmented care delivery. In contrast, volume-based care link financial compensation to patient health outcome, quality of care, and overall cost reduction. Value-based care emphasizes patient-centered outcome, cost effectiveness, and equitable access to care. And of course, nurses play a vital role in care coordination, chronic disease management, and prevention. I'm sorry. Okay. Nurses play a significant role in care coordination, chronic disease management, and prevention. We can see that the value-based care focus on optimized outcome at the minimum cost, and we have the evidence base to approve that that effective nursing care coordination can reduce hospital readmission by 25%, and it lower overall healthcare expenditure while improving patient satisfaction. Patient-centered care improves satisfaction and outcome, and of course, it can drive, when people satisfy more, they tend to come back and use more service. So it means the hospital can gain more economic outcome. Cost-effective practice reduce expense without compromise the quality. If we know that this is cost effectiveness and we use that, it should reduce the cost of care because they can, for example, nurse-led intervention can reduce length of stay of the patient. Reduce 2 days from 5. You mean if the regular model patient have to stay 5 days, using nurse-led model can stay 3 days. 2 days that reduce it means a lot of cost for the institute. As we say that nurses are the frontline provider who have the most sustained contact of patient and family. So nurses are the one who provide the value-based care. But it means that nurses have to expand the role, the care from the hospital base to more beyond than that. Nurses have to be like a care coordinator because they are the one who, is the central of the communication, connect patient with another health provider. It means that they can ensure seamless care and also efficient care for the patient. And it means that this coordination reduces fragmented care, and prevent unnecessary hospitalization. In terms of preventive care and chronic disease management, nurses that provide educate patients on lifestyle modification, medical adherence, and self-management technique. This proactive management chronic care, such as diabetes and hypertension, can prevent complications, improve patient well-being, and lower long-term healthcare costs. For patient education, nurses are empower patients to have knowledge to taking care of themselves, and this is very important part of the value-based care, because the nurse can provide information that evidence-based information that tailor to individual patient. This will increase patient adherence to care system and lead to better outcome. For fostering innovation in nursing, we have to admit that innovation in nursing is not just about create new device. It could be the process of problem solving and continuous improvement. We have to admit that nurses are the natural innovator because we are working with the patient. We communicate, we know, we have developed the relationship. We assess the problem, and that's why we can identify the solution. We develop nursing intervention as a solution at the point of care. Innovation from nursing is response to evolving healthcare needs of the patient. Innovation in nursing is about develop new model of care. Innovation in nursing could be process innovation. Nurse can design a new workflow to improve efficiency of care. It could be it could be technological innovation, integrating and use the new tool like telehealth to improve the care of the patient. For example, they can use the data as a predictive analytic to identify high-risk patients before they become critically ill. If they know that this, what they can change their behavior, how much risk that can reduce, many patients will, make it more clear for them that I better change my behavior to reduce the risk of myself. Another one is translate research. Nurse can take the evidence base from research and implement it into direct practice. So as a leader, nurse must be empowered the team to identify problem and develop effective solution. For the individual nurse to lead the future nursing, they must cultivate and encourage and support the creativity to support and resource allocation. And they must recognize as a nurse-driven innovation. They should develop the idea of problem-solving mindset, so they should understand that nurses are naturally identify gaps in care delivery. They can develop creative solutions. This innovative thinking is embedded in nursing process of assessment, diagnosis, planning, implementation, and evaluation. They should have the idea of continuous improvement The culture of innovation requires ongoing evaluation and refine of care process. So nurses must be empowered to question existing care and to improve the better care. Even they practice for a long time, they should be questioned whether I can make it better. And the innovation should happen at point of care as a solution. Wherever the care delivered, nurse direct patient interaction, provide unique insight into practical implementable solution that can transform healthcare delivery. And to foster innovation in nursing, healthcare system must cultivate innovation culture by empowering. Institutions must create an environment that encourages nurses to identify problems and propose solutions. Nurse-driven innovation have already made a lasting impact on healthcare. This innovation born from the direct patient interaction. Another thing is that integrate technology and informatics. The institution should integrate technology as a powerful tool for value-based care and nursing innovation. Electronic health record, telehealth platform, remote patient monitoring device can enhance communication and enable nurses to deliver care more efficiently. By integrating new technology, nurses can move beyond time-consuming administrative tasks and dedicate more time to direct patient care, improve health outcome, and building meaningful relationship with the patient. The last one is promoting interdisciplinary collaboration. Nurses must be full partner with many interprofessions, including physician, engineer, data science, and other professions to co-create solutions. By bringing our clinic expertise into the table, nurses can ensure that the innovation that develop is the care model is not only scientific sound, but practical and patient-centered focus. Creating lasting impact. Because our ultimate goal of nursing leadership is to create sustainable health outcomes, lasting impact requires us to address both economic and social effect beyond health outcome. For economic impact, nurses should demonstrate the economic value of nursing intervention or nurse-led model through data by tracking and reporting the key metrics such as readmission rate, length of stay, and patient satisfaction score, and turn it into economic values. Nurses should show how this nurse-led model or nurse-led intervention can reduce waste, can improve organization, financial health, and nurses should be the one who are making financial decisions on healthcare costs for nursing intervention and innovation. Regarding social impact, we have to think that true value is not just about cost, but also about equity. Nurses should lead effort to address the social determinant of health. A patient health is often more influenced by their housing, food security, and access to transportation than medical care alone. So we, as a nurse, we need to work with community as a partnership, build partnership relationship with the community organization to provide comprehensive care and holistic care. I will give you some example that one of my colleague, the group of my colleague work as a partner with community and for the project called remission diabetes, or we call diabetes remission. to, there are the several settings that employ this process, but as our Faculty of Nursing can be able to partner very well with the community, and we are only one setting that can have the proof of the M remission. So it's, right now we're trying to, analyze what is the core knowledge that we, or core activity that we should, is the core activity that make the patient can stop using medication for their diabetes and expand more scale up for another setting. We also, as a reader, we better address the root cause of health inequity to create a healthier and more resilient community while reducing the long-term burden on the healthcare system, demonstrating nurse commitment to social justice and its essential role in public health. It should be the time to prove and demonstrate that nurse can create social impact. To prepare for the nurse leader, healthcare is evolving in the period that healthcare is evolving rapidly, demand nurse leader with sophisticated competency beyond traditional skill. We have to shift from value-based innovation and lasting impact. It's not just change in philosophy, it's demand fundamental evolving evolution of nursing competency. The leading of future nursing demand a new generation of nurse leaders who are clinical experts, technology innovator, collaborative partner, and financial savvy change agent. Traditional nurse education must evolve by beyond clinical skill prepare the leader who can navigate to be the leader who can navigate complex care system and demonstrate measurable value. The core competency domain that I would like to present is that the first one is clinical excellence system integration. Nurses must be able to use the data-driven clinical judgment. Future nurses must integrate multiple data sources, such as lab results, remote monitoring, variable device, and population health analytics to identify at-risk patients, provide intervene proactively, and demonstrate the effectiveness of their care. They have to focus and shift from individual patient care to community health assessment, design scalable intervention for chronic disease prevention and management for complex health problems. And they have to be the care coordination mastery, leverage communication technology to prevent readmission and reduce costs. Second is technology leadership and innovation. They have to be digital literacy, be able to mastery the use of electronic health record, telehealth platform, data security, and privacy protocol. They have to use, evaluate emerged technology and advocate for the solution that improve patient outcome and workflow. They have to have design thinking, be able to apply systematic problem-solving approach, identify system inefficiency, develop prototype solution, and collaborate with interdisciplinary team, including many professions, to develop the innovation for the solution of care for the patient. And there should be the change leadership. There should be navigate continuous transformation while maintain team performance and foster culture and embrace innovation, continuous improvement. The third is interprofessional leadership and financial literacy. They have to be able to build effective relationship with physician, administrator, community stakeholder, communicate effectively across disciplines, while advocate for patient and nursing intervention. They should understand healthcare economic platform, perform cost benefit analysis, and articulate the economic value of nursing intervention to adjust resource and demonstrate the return of investment for nursing intervention. The last one is patient ethics and advocacy. They must actively engage in policy developments and educational reform. They should understand about engagement in legislative advocacy, and understand that the education, even in undergrad education, curriculum needs to be redesigned. The transform nursing education for future excellence it means that we need to move from traditional practice to system leadership. The transition have to change from individual patient care to population health management, represent fundamental shift in nursing education. Future leaders must understand healthcare economic, demonstrate return of investment, navigate complex ethic landscape involving AI and data privacy. This means that curriculum needs to emphasize more about design thinking, interdisciplinary, and continuous innovation to prepare graduates who can lead transformation rather than simply adapt to change. Nursing education must involve from teaching technology, changing from teaching technical skill to develop strategic thinker who can lead healthcare transformation while maintain professional core value and patient advocacy and ethical care. I would like to finish my last slide that the future of nursing leadership is not just about manage people, it's about leading change. By driving value, fostering innovation, and create lasting impact, we will shape a more sustainable healthcare system. Thank you.
Thank you, Dr. Ratenthorne. I will now invite Dr. Im to the front to present you with your plaque.
Thank you so much for sharing your insightful lecture on global leadership in nursing. Thank you. This is a token of our gratitude for your lecture.
We have to move there. This is our assignment. Thank you. Thank you so much.
Okay, so that wraps up our third presentation, and we will have a brief intermission before beginning our next presentation at 11:45. So again, please use the QR code or link to complete your form for the CNE credit, and enjoy some refreshments outside. And if you have any questions for Dr. Ratenthorne, please submit them to the check-in desk or online through the YouTube live chat. Thank you, and we'll see you at 11:45. Hello, everyone. Please be seated for our next presentation. At this time, I'm honored to introduce the Laverne Gellman Lecture in Nursing presented by Dr. Fan Hao Zhou. Dr. Fan Hao Zhou is the Senior Vice President of Kaohsiung Medical University in Taiwan and a distinguished professor in the Kaohsiung Medical University College of Nursing. She earned her PhD in nursing from the University of Texas at Austin, right here. Woohoo! And as a trailblazer in nursing education and research, specializes in multiple areas such as maternity nursing, parental child nursing, nursing education, women's health, gender issues, traditional Chinese medicine and nursing, problem-based learning, and quality of life. Dr. Zhou's scholarly contributions span over 180 peer-reviewed publications and numerous book chapters. She has served as a member of multiple governmental and academic committees, currently serving as executive supervisor of the Kaohsiung City Nurses Association and vice chairman of Nursing Education Committee of the Taiwan Nurses Association, among others. Dr. Zhou is a passionate leader who continues to shape the future of nursing across Taiwan and globally. Please join me in welcoming Dr. Zhou back to UT Austin School of Nursing.
Ladies and gentlemen, it's my great honor to present my topic, the global leadership in maternal health and nursing education from local research to international impact. This is today's outline. So I think what started here changed the world. This is UT Austin. I would like to say UT Austin very thank you, and especially to my lovely teacher, Professor Doreen Walker. Kiss me. Yeah, we are very good friend and teacher with a student, and my advisor, Professor Kevin. She was passed this year, so I feel very sorry. But I think UT Austin changed me a lot. So I would like to share what UT changed me. So first, I will share some articles cited by the UK guideline for the management of nausea and vomiting. So. My major, first I will talk, my major research focus on maternal health. For example, symptom management, especially for the nausea and vomiting, low back pain, fatigue, and also the quality of life for SIMS. And for the nursing education, for example, the problem-based learning, team-based learning, and the interprofessional learning. So I do both qualitative and quantitative research. My first grant from the Taiwan National Science Council is 1998. So the first grant is a phenomenology study. And then I come to UT Austin. So this is my dissertation. This is where most research begins. So I do the adaptation to practice in Taiwanese women who experience different severity of nausea and vomiting. So Dr. Walker gave me many suggestions. So from 1998 till now, I almost used the psychoneuroimmunology paradigm to implement the comprehensive approach to my study related to nausea and vomiting. So this, I do the psychosocial issue, and I also do some cytokines and for the quality of life. So here is some of my articles. And I would like to share in 2016, I have 4 papers cited by the Royal College of OBGYN and for the green guideline for the management of nausea and vomiting of pregnancy. And then they also published an article in 2024. So talk about 3 articles. So today I would like to share these 3 articles. The first article I cooperate with Dr. Walker. So we examined the psychosocial factors related to nausea, vomiting, and fatigue in early pregnancy. So this is secondary data in Texas. So you can see even a small research actually also can be cited in a guideline. So if we do a very well design. So we found around 74% of the pregnant women report they have a nausea and vomiting. And depressive symptom had the highest correlation with nausea and vomiting. Social support was negatively correlated to nausea and vomiting. And this is my dissertation. So I examined the relationship between these variables, and it was published in the top 1 journal of International Journal of Nursing Studies. So the purpose of this study was to examine the relationship between the above variables. So it is a correlation of cross-sectional research design. So it's not a very AI something, but very basic. So also was cited by the guideline. So I'm very honored. And we found pregnancy-related nausea and vomiting was experienced in varying degree by 77% of women in Taiwan. So we know in Texas how many? 74, right? Around 73.5. So in Taiwan, 77. So I study many research. So the percentage just between 70 to 80. So that means most of the pregnant women, they have a nausea and vomiting. So this is very important that we have to help them to deal with. So we also, this study also indicated around 37.6% of the variance in maternal psychosocial adaptation was explained by the severity of nausea and vomiting, perceived stress, social support, and pregnancy planning. This is the stepwise multiple regression. So because pregnancy takes around 10 months and divided to 3 trimesters, so after my PhD degree, I also do a longitudinal study to examine this relationship. So the pattern, to see the pattern and the relationship among these variables. So we can find one-way ANOVA show the nausea and vomiting was significantly different, and the first trimester is higher level than the second and the third. And for the perceived stress and the social support, they are non-significant. For the fatigue, first trimester and the third trimester was higher level than the second trimester. So we always health educate the pregnant women. You can do many things during the second trimester. Okay, so that provided the evidence. And the mixed model show fatigue and nausea and vomiting was correlated, and perceived stress also correlated with nausea and vomiting. So from here, we know this study provides a more comprehensive understanding and evidence-based data of the pattern of and the relationship among the above 4 key variables for pregnant women. And then we can, the healthcare professional, we can provide a more appropriate or precise strategy to help them. So here are the above 3 articles. And then I would like to share from local to global leadership. I think we know what is global nursing leadership, advocacy, or policy influence, education, research, dissemination. The barrier to translation is saying that we have many opportunities for nurses to do. So, for example, using local evidence to inform global maternal health strategy. So we have chance to cite it by the guideline in UK. So that's I'm very proud. And we also to do some policy development. So here, nearly 35 teaching year. From research to maternal nursing textbook. These are the five versions for the textbook, and I'm the chief editor from 1913. So I published more than 10 books, textbook, and they use in the school. So I also from Taiwan to Solomon Island. And from 2010 to 2014, our team go to the Solomon Island. So they are all RN or midwifery. So we provide some educational program to teach them. So around 5-year commitment to the Solomon Island. So we also hold a higher nursing education forum. In Solomon Island, there are only one state university. So that's our pressure. So this is the Prime Minister Phillips. So first time when I arrived, so we just made him. And we also do some neonatal resuscitation and NRP program. So we cooperate with the pediatric physician. So the local newspaper, they always mention what the Taiwan's team do. So I think this is a very special experience for me. So during that period, we also visit the village. So we can see the autoclave, very old and very, I think, not good for using, right? So our team, we design a new one, very new one, and do the donation of the autoclaves to the Solomon Island. So she is the president of the university. The nursing university. And we also donate some midwifery instrument kits, and they can use the autoclave to do the sterilization. So I think that's a very, we are very happy to help them. So I was invited to write an article in Mandarin to say the experience, and our team also published a Mandarin book, textbook, to share the 10 years experience. And WHO data show that the maternal and the neonatal mortality rate in Solomon Island decreased significantly from 2010 to 2013. So we are happy. We are the one of the team. So it's a very very good experience. From that, because I am the director of the master program, so I also recruit their teacher. In the Solomon State University, they have 16 faculty members. So since 2010, we assist 5 teachers to obtain master degree in KMU. So here are all the students. So I think that's a very special experience for me, and I learned a lot to see another different country and need us help. So, and we provide very specific help, so it's good. And I also serve as president of the Kaohsiung City Nurses Association for 2 terms, 6 years. So during last, in 2012, so the COVID-19 pandemic, and I cooperate with the Kaohsiung City government. This is on the TV. So we the mail train every day on the TV to teach all the people how to the data, how many cases, something, and this time they ask nursing to help to provide home care for infant and young children for epidemic prevention, because nobody know how to do it. So, okay, I say, okay, I do it. During 3 days, we finish all the thing. And to do the, because on TV, there are special equipment. So I also serve as the committee member of the government for the Women's Rights Committee. So every year, we have a celebration to the Kaohsiung the mail train, so to do for the women's right. So here, I also with the Kaohsiung City Council Speaker, Chung. So we do, this is Chinese, it's me impact. So, and then the next is that I will talk some practical steps for nurses. I think for nurses, we can, how to build a global impact. I think in addition to previous PowerPoint I share, and I think we also can do some participant in international nursing organization. So I do that, I will share later. And the educational resource for the CNE program or the global health courses, I think that will all are very good. So from here, I would like to share some nurse education issue. So I do a preliminary study of current situation and the competence of doctoral nursing education in Taiwan. So in Taiwan, now we have 11 PhD programs from 1997 to 2020. So we want to know what's the program is okay or not, so to see. And overall, we found the doctor nursing program in Taiwan aligns approximately with global trend in nursing, especially with United States, because most of the faculty we graduate from United States, so it's good. But this study also suggests that international and the national resources should be incorporated into the cultivation of various competence and curriculum quality control. I think that's for our PhD program, so we have to think about it. So, and then I also work with my PhD student. We publish for the interprofessional education for healthcare students, so to see the IPE effect. So we found IPE had a significant positive impact on healthcare students' knowledge, but on readiness and attitude was not significant. So need further investigation. And we also do a problem-based learning. I learned problem-based learning in Canada in 2002 after I graduated from UT Austin to study the PBL for 1 month, around 8 credit hours. So I also teach our faculty and the college and the other faculty in Taiwan to do the PBL. So now PBL in nursing program are very popular and common. So we do some the meta-analysis to see. So we can find PBL had a great positive effect than traditional learning on critical thinking, analysis, and evaluation. But on problem solving and self-confidence need further investigation. So from the meta-analysis, we can understand and can design the future research. So from the research and the KMU, so I go to the Taiwan Nurses Association of Nursing Education and the Asian and the Pacific Alliance for Nursing Education, we call APAN. So because I was served as the president of the Taiwan Association of Nursing Education, so we host the third Asian Congress in Nursing Education. This year, I think will be the 5th in Australia. So from the conference, we also learn a lot. So here they are from the Thailand, Indonesia, and Philippines. So this is for the APAN. The APAN, you can see these are the participant institutions. So from the Asia, the different country. So this is the first meeting in Taiwan, south of Taiwan. So, and I was served as the chairperson on nomination and the election of APAN. So we do a online vote. Wow, I learned a lot because you know how to do and to teach many countries member how to do it. So meeting and the meeting, and then finally we completed it. And from the president from Taiwan to Turkey. So now we'll go to Taiwan or Australia. So I think that from the local to the international. And then I would like to talk about nursing education. This is my, I also very interested to the nursing education. I do some innovation. So this is, I work with my PhD student. We write this book just called Innovation in Nursing Education. So, and I also do some innovation things. So I bring here because I just discuss with the faculty. So this is designed for the senior nursing student when they before graduation, and also for the new nurses. They were familiar with the emergency room for the medication. So we do some education, and this is a small research. And till now, I also work with my student to design a electronic textbook. The book we can use some the AR or VR to the QR code, and the question will come out and can figure out, can answer the question. So the younger generation, they are very happy to learn that. And at the hospital, they also want to borrow. So because for the student education is more complicated and more comprehensive, but for the health education, we design more simple for the health education. So this is also I'm very interested to do. Till now, I work with our undergraduate student. This is the undergraduate student, level 3, do it. So it is very good. And I also have 4 invention patents. This is for my nursing graduate student. These are the, they come from, these 4 students, they come from the School of Chemistry because they are interested of my tools. So we have I work with my graduate student for this tools. This is we call the from here. This is the original, and to here. This is the prototype, and that's for people. If they have the incubator or something, they cannot brush their teeth by themselves, and then this tooth can just put the clear water to the mouth and then suction the dirty water out. So that's why we have the 4 patterns to do it. So this is the student we cooperate for 10 years. So and then we have the first generation to have the tools. So and also we won the Taiwan innovation in Taiwan clinical innovation. So and now I am the vice president, senior vice president. It's challenging and very hard work, but I still keep learning. And so this is what I'm doing from last year. So and then I also a committee member for the Ministry of Education in Taiwan for the nursing group. So this year we began to do the renewing Taiwan core competence. So this year I host around 65 directors and teams participate in this meeting in Taichung. So we try to renew our core competence because the world changing. So for example, the informatics, the AI, so we have to also renew our core competence. So everybody eager to know the core competence when we'll finish. So we will publish an electronic book in March 2026. So now we work from 2024. So this is what we are doing. So I also the convener of the Center for the University Social Responsibility in Taiwan, Ministry of Education. So now the social USR, we call the USR, University Social Responsibility. So this is a very important task in Taiwan for all the university. So I am the only nursing person. So the other are all other profession. So I'm the only nursing person. So I still keep learning. Okay. So and I also the deputy convener for the Ministry of Education. So now our Ministry of Education encourage faculty to write a grant to apply. So we apply the research grant, especially for teaching. So that you can write a teaching, and it's a small grant, not too big. I think around 10,000 US dollar to 15,000, not big. For the NIH is bigger, but for the teaching grant, not big. But most of the faculty in Taiwan, I think they are all encouraged to do this grant, because if you receive this grant, you feel honored, and they do many innovation teaching. So I think it's good for our students. So you can see this is last year. So this is this year what we are doing. So I think UT Austin changed me a lot. Still keep changing the world, right? So I think I would like to say thank you again for the UT Austin, for all the faculty, although some faculty are retired or pass away, but I always keep thank you in my mind. So I think this is today what I'm sharing. Thank you very much.
Let's give Dr. Zhou another round of applause. And we have Dean Im who will present the plaque to Dr. Zhou.
Thank you so much for sharing your global leadership in maternity nursing and education, especially in Taiwan. And this is a token of our appreciation. Thank you.
Thank you. Okay, we come here. Thank you. Thank you very much.
Okay, so that wraps up our fourth presentation. And we will have another 30-minute intermission before beginning our next presentation at 12:45. So you have about half an hour for lunch, and the lunch will be served in the reception area outside. And you're welcome to bring your lunch here to this room, and or find other places around the conference center to have your lunch. And if you have any questions for Dr. Zhou, please submit your questions at the check-in table. And for those of you who are online, please submit them by YouTube live chat. And that's it. So we'll see you back at 12:45 for our next presentation. Thank you. Good afternoon, everyone. I hope you had a great lunch, and if you're still eating, please feel free to continue enjoying your lunch. So it's my great honor to introduce our next Laverne Gelman Lecture in Nursing, presented by Dr. Reiko Sakashita from Japan. And unfortunately, Dr. Sakashita is unable to be with us in person today, but she has provided her full lecture recording to play for you after this introduction. So we will share that with you shortly. So Dr. Reiko Sakashita is the Executive Vice President of University of Hyogo, Japan, and she's a nursing foundation professor teaching nursing research and theoretical nursing to undergraduate and graduate students. As a researcher, Dr. Sakashita has conducted over 35 studies and aggressively disseminated her findings with over 330 publications that have been continuously funded during the past decades. Dr. Sakashita is also a researcher in data driven healthcare systems, analyzing big data from health checkups and receipts using AI leads to population based approach and intensive individual care to prevent severe diabetes. Oops. Okay. Her research focuses on developing comprehensive nursing support systems for older adults in both community and institutional settings, with particular emphasis on nutritional care and mealtime support to enhance quality of life and foster autonomy. Dr. Sakashita is an associate editor of Health Emergency and Disaster Nursing, an advisory board member of the Advanced in Nursing Science, and a life member of the American Association of Physical Anthropology. So, without further delay, we will now play Dr. Sakashita's presentation.
My name is Reiko Sakashita, and I'm an Executive Vice President and Professor of University of Hyogo. It is a great honor to have this opportunity to speak with you all today about nursing care for older adults in Japan. I would like to express my deepest gratitude to the team of the University of Texas at Austin for organizing this symposium. My topic is Caring for Super-Aged Society, Geriatric Nursing and Health in Japan. Before I begin, let me briefly introduce the University of Hyogo and my college. Hyogo Prefecture is located in central Japan, next to Osaka and not far from Kyoto. My university has 6 faculties, 9 graduate schools, 5 research institutes, and total 17 facilities across the prefecture. My college, named College of Nursing, Art and Science, designed by the famous architect Tadao Ando. It is very beautiful, but since it is an art object, very hard to use. Mr. Andrew also designed the Art Institute of Chicago and the Modern Art Museum on Fort Worth. Today, there are more than 300 nursing universities in Japan, but our school was among the pioneers. Our first president, Dr. Hiroko Minami, served as president of the Japan Nursing Association and president of the International Council of Nurses. Here is an overview of today's presentation. First, I will talk about the current situation of Japanese super aging society. Next, I will describe some distinctive services that have been implemented in Japan to address this issue. Third, I will share the work of my research. And finally, I will discuss future direction. This chart illustrates Japan's demographic evolution, showing both historical data and future projections of population by age group. Notably, the population of the individuals aged 55 and over is expected to rise significantly, while the working age population is expected to diminish. By the 2040, the aging rate is estimated to be approximately 35%. The pattern underscores the demographic pressure our society faces, highlighting the need for sustainable care and support system. Japan's older population is rapidly increasing. This brings more complex nursing needs, more people with multiple illness, more dementia, and more isolation. We need care that is personal, long-term, and community-based. At the same time, our health and long-term care systems are under strain. We don't have enough nurses, and burnout is a serious issue. Financing long-term care is becoming harder, and there are regional disparity and the need for policy innovation. Despite these challenges, Japan has a world longest life expectancy. Women have ranked first for 40 years, and Japan also led in health life expectancy. Healthy life expectancy means the number of years people can live in good health, free from serious illness or disability. Why? One of the secrets may lies in Japan's healthcare system. Today, I will introduce three distinctive systems. First, community-based integrated care system. Second, long-term care insurance system. Third, nursing-based small-scale multifunctional in-home care. We call it Kantaki. Let me begin with a community-based integrated care system. This system is a comprehensive model developed in Japan to support older adults in continuing their lives in familiar community until the end of life. This diagram shows how the community-based integrated care system links healthcare, housing, and preventive service around the older adult, emphasizing its localized, integrated, and person-centered approach. In addition to universal health coverage, Japan has a long-term care insurance system. Japan's long-term care insurance system was introduced in 2000. It covers all people aged 65 and over, and some aged 40 to 64 with specific conditions. It is funded by public money and insurance premiums and provides service at home, in facility, and in the community. Third one is nursing-based small-scale multifunctional in-home care called Kentucky. Kentucky is a Japanese community-based service for older adults who need daily support. It combines daycare service, short stay service, and home visit service. So this flexible system allows people to continue living at home while receiving medical, nursing, and daily life support. This system is led by nurses. Up to 29 people with a long-term care certification can register for Kentucky. And depending on their needs, they can get support through day service, short stays, and home visits. Kentucky has a full future. One, support for a smooth transition to home life immediately after discharge. Second, continued support for home-based living during periods of unstable medical condition. Third, end-of-life care for terminal cancer patients and others. And respite care for families. Let me share two of our research projects. One is a data-driven healthcare system, and second is community support program for the well-being of older adults. So there is a challenge in Japanese insured healthcare system. So data analysis have revealed that only 5% of severity ill patients use 40% of medical expenses. So optimization of medical expense can be achieved by preventing serious illness. So let me introduce with data-driven healthcare system. So in Japan, all citizens are required to undergo regular health checkups, and the big data from these checkups is stored by insurers. That means the local government and companies. By analyzing more than 20 years of accumulated data, we can predict health risks based on these predictions. So, based on these predictions, we apply two strategies, population approaches and high-risk approaches. I will explain the population approach and the high-risk approach. And population approach lowers the risk of the population as a whole with a method which include environmental improvements, campaign, and education. And the high-risk approach through early detection and treatment, which includes that nurses visit high-risk individuals, listen to them, provide hands-on care, and foster their self-care ability. So we currently use AI to analyze big data and stratify people by health risk, and then take a population approach according to group characteristics. And we also developing a device to encourage self-management for low and medium-risk residents, and advanced care management for high-risk persons. So, based on big data analysis, an application was created to predict diabetes severity. So, when residents enter the result of their health checkups, the risk of diabetes is displayed with a regional display distribution like this. Upon achieving the next target value, so achieve goal weight, one can understand how much the risk decreases. So using this device, we would like to promote a self-care action and utilized as a tool when public health nurses provide health guidance. In the population approach, we create heat maps to show each region's strength and weakness and where improvement is needed. So green means good. That was a strength. And red means poor. That show weakness. So people can understand where to improve. As a high-risk approach, we developed nursing care module for home visit to high-risk patients. Foster self-care skill by understanding the body susceptibility to invisible vascular injuries. First, we listen to the patient about his or her physical condition and daily life. Respect a person who has a lot of experience and try to improve one's life. And second, enhance understanding of their body and illness through foot care. Support to take interest in his or her own body. Carefully look at the foot with the patient. Touch dorsal foot artery and check the sounds using the instrument Doppler. Assess neuropathy, tractical pressure, vibration, touch, tendon reflex. Assess blood flow disorder, checking the pulse, blood flow sounds, skin temperature. We visit each patient to take deliver care to them. Second, my research is a community support program for the well-being of older adults. The program is designed by combining health promotion initiatives with independent activity of older people. It is structures around 3 forms of ikiru. I show the Japanese character, 3 types of Japanese character, but all pronouns we call ikiru. First, ikiru, to live, is a physical well-being. Second, ikiru means emotional well-being in enjoying life. Third, ikiru means well-being through the realization of one's innate capacities. So, using 3 types of ikiru, we would promote well-being in local community. So, by nurturing these 3 aspects of ikiru, older adults are encouraged to express their individuality and to live more freely and richly within their community. So we would like to promote well-being in hometowns. This program is held once a month at a single site within each elementary school district. Each session has about 30 to 40 participants. The program consists of 2 parts. First, a themed community event, and second, small group activity tailored to patient interest. So this is an example of our activities. We held a sports day with a safety measure for older adults. So after 6 months of intervention, significant improvements were observed in blood pressure, physical performance, and bone density, suggesting that the intervention to improve physical function was beginning to show effects. So, to summarize, a key feature of geriatric nursing in Japan, uh, prioritizing independent living in familiar communities, a culture that respects aging and values family connections, emphasize on support that enriches daily life. So we aim to holistic community-rooted care that sustain life and person's dignity. Today, I could not introduce everything, but I highlighted the strengths of geriatric nursing in Japan and person-centered care, focus on quality of life, independence, and community support, dementia care, community-based support, and family inclusive practices, end-of-life care, respect for natural death and home-based care models, disaster preparedness, strategy for protecting old adults in emergencies, and nursing education, training systems, and gerontology specialized nurses. So Japan's experience in building a person-centered, culturally rooted system of care offers value insights for continue approaching super-aged status. Thank you for your attention. I hope this presentation will be an opportunity to expand our network with you all. Thank you.
Oh, her voice is so calming and soothing. Well, that concludes our presentation, our fifth presentation for the day. And we will now have a 30-minute intermission before our next presentation at 1:45. Again, please feel free to submit your questions at the check-in table. And for those online, if you can submit them through the YouTube live link. And please feel free to enjoy some refreshments that are outside. Thank you. Hello, everyone. Welcome back. I know it was a pretty long break, so and we just had lunch. So how about if everyone gets up for a quick stretch break? We'll just stretch. I would lead you in a little exercise, but maybe next time. Okay. Yeah, when you're ready, please take your seats. I hope that was better than nothing to get our blood flow going again. So at this time, I'm honored to introduce the George and Diana Sharp Perinatal Lecture presented by Dr. Chung Kim. And Dr. Chung Kim is a professor at the School of Nursing, Soonchunhyang University. She received her BSN and MSN from Seoul National University and earned her PhD in Health and Nursing from the University of Tokyo. Dr. Kim currently serves as the president of the Korean Society of Nursing Science, as well as a board member of the Korean Federation of Science and Technology Societies and the Korean Accreditation Board of Nursing Education. Dr. Kim previously served as president of the Korean Society of Women's Health Nursing and Korean Society of Maternal and Child Health Nursing. She has also served as editor-in-chief of Asian Nursing Research, Journal of Korean Academy of Nursing, and Korean Journal of American Health Nursing. Her recent work focuses on digital health interventions for pregnancy stress, and in recognition of her contributions, she received the Prime Minister's Commendation in 2024 and the Deputy Prime Minister and Minister of Education Award in 2023. So please join me in welcoming Dr. Kim.
Thank you for introducing me. Good afternoon. I prepared good morning, but now this is time, good afternoon. Yeah, as introduced me, my name is Chung Kim, not Chung Im, Chung Kim. Yeah, I'd like to express my heartfelt thanks to Dean Dr. Im and all members of UT, University of Texas, Austin, for this wonderful invitation. It is truly an honor to be here as the 2025 Georgie and Diana Sharp Perinatal Lecturer, and to have this opportunity to share Korea's experiences in maternal nursing. And today I'll talk about maternal nursing in Korea. Hope this test talk inspires collaboration, dialogue, and discussion, and new ideas among all of us dedicated to perinatal care and women's health. This figure shows our campus and clinical training site. Our campus is located in main campus is located in the center of South Korea. South Korea. Yeah, and we have 4 hospitals: Seoul, Bucheon, Cheonan, Gumi. So, and other SIMS, we have a research institute too. And it takes 1 hour by car, and this area, Bucheon, is 30 minutes. Cheonan is 1 hour. Yeah, Gumi is by KTX 1/2 an hour. So it's very closed, and we communicate each other. Okay. Yeah, today's talks 5 parts like this. First, introduce to Korean maternal health achievement. I will explain maternal health with birth trend. This figure shows birth trend from 1981 to 2023. Yeah, as you know, as you see, it very sharply dropped. And from about 880,000 in 1981 to about 230,000 in 2023. This represents a nearly 74% drop, very big, yeah. So in our country, university students very easy to enter to university. Yeah, this slide about shows about maternal deaths and maternal mortality ratio from 2012 to 2022. Blue line is maternal mortality ratio, and orange color, your university color. Yeah, it maternal death, but your university is very vivid. Not happy. Yeah, that's correct color. Yeah. 2012, its mortality ratio was 9.9, and there are for 10 years there are some fluctuation. But 2022, it was increased 11.8. We think maybe it effects of COVID-19. In 2021, it decreased. It was decreased again, and now 21. So it lower than OECD value 11.8. When we examine the main causes of maternal deaths in Korea, the leading factors are postpartum hemorrhage, obstetric embolism, and hypertensive disorders of pregnancy, such as preeclampsia and eclampsia. These causes highlight the importance of emergency obstetric care, timely intervention, and preventive management in reducing maternal mortality further. Here we see how maternal age is changing in Korea and why it matters. Left graph, birth stat 2018 to 2023. Age-specific birth rate are falling in the 20s. Yeah, very lowest 21.4. 네. So birth rates are falling in the 20s and early 30s. The 35 to 39 group stayed steady with a small rise in 2023. More women are giving birth later. That means bringing new health risks. Right graph, maternal mortality by age. Risk rises with age. In 2022, ages 35 to 39 and over 40 years old were both 12.4. It means higher than OECD average 11.8. Rates improved since 2012, but older mothers still have higher risk. So key message like this. As maternal age increases, we need tailored risk-sensitive nursing. Nurse-led care such as MFICU programs and AI-based early risk tools is essential. Among causes of maternal death in Korea are direct and indirect. 81% were direct obstetric causes. This shows a need for fast, specialized care. Deaths in the postpartum period doubled. Risk continues after birth. Other obstetric conditions also rose, showing unexpected complications. Key point, many deaths are acute and preventable and tied to care quality. This urgent reality led Korea to establish the MFICU system to enable early detection, rapid response, and intensive monitoring for high-risk mothers. This slide explains underserved obstetric areas and equity in Korea. It shortly OCUA. Out of 250 districts, 54 have no obstetrics, gynecology clinics, or prenatal hospitals. The government named 38 regions as OCUA. Care is weaker there. Inadequate prenatal care is only 7.2% in OCUA. Women in OCUA also face more complications and need more transfusions. Some groups are hit harder: teenagers, 28.1%, women with disabilities, 6.4%, non-Korean women, 10.7%, medical aid dependents, 15.2%. Low-income women and those living in OCUA have higher risk overall. The map shows where these regions are. We must close this gap with targeted service, stronger referral system, and nurse-led support. Now we move from the situation to the support system. Korea has a multi-level governance model. I kindly ask for your understanding that the name of Korean institutions may not have a precise English translation. Yeah. This slide shows the picture of Korea's maternal health system. It is a multi-level governance model, neonatal, national, local, clinical, community. The maternal support system is under the Ministry of Health and Welfare. At the top is the National Medical Center. Below it is the Central Maternal and Neonatal Center. Then the Maternal Medical Support Team. These bodies work across 5 pillars. I will explain them on the next slide. I have served as an advisory member to the Central Maternal and Neonatal Center. 5 main core programs. Together, they are the base of Korea's policy. These core programs improve infrastructure, regional equity, access, and continuity of care, especially for high-risk underserved mothers and babies. You can see number 1, MFICU support program. Number 2, regional NICU support program. 3, obstetric care underserved area, OCUA. Number 4, MUA, medically underserved area support program. Number 5, high-risk pregnancy care network program. Yeah, maybe time is short, and please look in detail. Yeah, high-risk pregnancy care network links clinics and hospitals and trains staff and speeds referrals. Yeah, this slide shows status dashboard of Korea's maternal and neonatal health system. And left one is 2023. Blue is decrease. Total birth, total fertility rate versus by mother aged 35 years older, low birth weight infants, preterm births all decreased. But maternal death is increased 9.52%. Compared to these conditions, 2024 institutional capacity of maternal health support programs, tertiary centers, MFICU beds increased, NICU beds also increased, but regional centers decreased, OCUA also increased. So it's a very big problem. The trends show that we need more research to understand the reasons behind such changes. To respond, Korea launched the severe, it's not appropriate. This tells us capacity is concentrating in large centers, but regional gaps are more widening. By 2023, infertility experience among married women was 17.2%. Mental health is also critical. About 1 in 5 report depression in the second trimester and 16.3% after birth. Yet, although many women experience prenatal depression, only about 6.8% receive an actual diagnosis. At the same time, the number of mothers decreased by 24%, but cases of postpartum depression increased by 70%. These trends show that we need more research to understand the reasons. To respond, Korea runs, this is a name, Severe Infertility and Depression Counseling Center. We established this system. It offers counseling, referral, and forest therapy for stress relief. Centers are located nationwide, as these figures and tables shows. Supporting mental health improves family health and birth outcomes. This is another organization, 코프와 아이사랑 means baby love. 코프와 아이사랑 is very closely related. These two organizations support mothers from pregnancy to postpartum. They provide reliable information, maternal and child health handbook is this handbook made with various languages, many languages, and Braille, and education on breastfeeding and sexual health. They help children with genetic metabolic disorders and support single mothers through mentoring and self-help groups. They train postpartum care workers. Dr. Kim explained postpartum care center. This organization trained some workers in working postpartum care center. COFA leads public campaigns like Pregnant Women's Day on October 10. In short, COFA and 아이사랑 connect services and community to strengthen maternal care. KICCE, also a big organization to support mothers and families through research, policy, and training. They study early childhood care, publish the journal Child Policy Forum, and give policy advice to the government. They also run training for postpartum care staff and evaluate postpartum care centers. I also contribute to proposing research topics, writing editorials on high-risk pregnancy, and serving on evaluation committees. Right side is my papers. The Korean Society of Maternal and Child Health is preliminarily led by obstetricians and pediatricians. There was no positions in nursing. But I was invited to join their leadership. In these roles, I served as both vice president and chair of the education committee. During my position, I identified a critical gap. Although legislation on maternal fetal intensive care unit, MFICU, had been enacted, there were no structured training opportunities for MFICU nurses. To address this, I conducted a needs assessment and job-related research, which led to the development and evaluation of an educational program tailored for MFICU nurses. This program has since been implemented 1 to 2 times per year, and to date, more than 1,000 clinical nurses have completed this training. On the right are the core modules composed of high-risk care and perinatal monitoring, hemorrhage management, and case management. My part focuses on algorithm-based management of preterm labor. This section shows how I led teams, built programs, and worked with global partners. As you see on this slide, I'm the lead author of many books. I added some many books many books, but it is omitted. So I wrote some women's health nursing this year. That is published the 11th edition, and women's health nursing and elderly nursing, incontinence prevention, wound management. It's all in Korean. I am a co-author of Korea's official publication ethics guideline as the only nurse scholar. Research tools in women's health, research tools in elderly health, and actually it's not updated version. And translated scale development and theory and their application also translated into Korean. And primary health management for the elderly. When writing books, I did not just oversee the process, I edited every chapter. My careful review brought coherence to the entire work, and co-authors often express their admiration. I have a style that values creativity. I have also served as editor-in-chief for 3 journals, WHN, Women's Health Nursing, and Asian Nursing Research, Journal of Korean Academy of Nursing, JCAN. WHN, this is W, but center is connected into orange color. Yes, I mean, this logo also I developed, and it's an umbilical cord, mother and fetus. This over top page, cover page. It looks like a fetus. Yeah, breathing some amnion. Yeah. This was also as I on editor-in-chief. 3 journals also increased the impact factor and Q ranking, Q3, Q2, Q2, but ANR in this year, Q1. So I dedicated over 10 years to developing these journals. I also served on the Kamje committee. This work supported the growth and quality of all 3 journals. As an editor-in-chief, I reviewed the manuscript every morning, early in the morning, and made quick decisions to keep the process efficient. Even when I suffered from frozen shoulder or painful calcification, my motivation came from raising the journal's impact and quality. I invested deeply in the work, sometimes reading and editing entire manuscripts when others only expected a partial review. This commitment often surprised co-authors and impressed the senior professors who came to trust me and invited me to collaborate. This is already introduced. Yeah. This slide showed my leadership beyond nursing. I served as a director in a National Science Federation. I connect nursing with wider science through joint project, policy advice, and outreach. This work was recognized this year. I received some, this year, the Prime Minister's Award on Science Day. This slide shows the research and technological innovation, I will say. It shows the measurement scales I worked on from 1999 to 2023. From 2019, I am involved into maternal health nursing. Previously, I studied with middle-aged women, but it's changed because of the fund. Yeah. From 2019, I got a 3-year project fund, and 23, 5-year project from the National Research Fund. So it was big, and yeah. So from 2019, I developed the preterm birth risk scale. It was repeated. I talk and named PUBRAS K. And this year, neonate preterm baby oral feeding readiness scale was also developed. This scale is the PUBRAS K, or 23-item scale for preterm birth risk. I began to start in 2019. During COVID-19, it was a difficult time to meet pregnant women, so progress was slow. I finished the study and published in 2023. But this scale helps the screen pregnant women early and guide nurse-led triage and offer timely counseling. This is my current study. Our team built a mobile app connected to a wearable. It gathers heart rate, sleep, steps, and SpO2. Inside the app, we also use PUBRAS K and a pregnancy stress scale. By combining biomarkers and risk scores, the app can flag early risks and provide simple, tailored advice to mothers. Goal is early risk alert and personalized coaching. This study looks at mistreatment during pregnancy and postpartum in Korea. We measured 4 important concepts for maternal health: continuity of care, shared decision-making, and respect. Results showed when the mistreatment index is higher, continuity care is lower, autonomy decision less, respect is reduced. Protecting women from mistreatment is essential for safe, respectful care. This is our GISTER, Gendered Innovation study. My leadership has also been about creating opportunities. Government agencies like GISTER recognized our work and provided funding, which allowed us to expand the project, increase visibility. I believe that every challenge is solvable. When others ask us, can this be done? Yeah, I already, yes, I can do. I take responsibility as a top leader to find solutions. This has built a culture where people know that working with me leads to results. With the support from GISTER, about 20 million won, we ran a forum and seminars and then published the book Sex and Gender Differentiated Nursing Across the Lifespan. This book is released this year. We are now preparing in English version edition. If your research shows sex or gender difference, I invite you to join us as co-authors for the next edition. Dr. Dean Eunok Im is also a co-author of this project. I'm grateful for her guidance and contribution. At the World Korean Scientists and Engineers Convention, I joined discussions on global collaboration as a panelist. With cost funding, about 20 million won or so, we built a communication platform for young nursing scientists. We conducted a needs assessment and provided targeted lectures and workshops to support their careers. This project connects Korea's nursing scholars with the global science community. Our efforts were recognized, and we have been selected to receive funding again this year. I'm committed to operating the program even more effectively to expand its impact. Alongside these activities, my team and I also co-authored the paper shown the slide, further strengthening our collective scholarly contributions. Let me introduce another type of project. This project began with a proposal from the KDCA, CDC, kind of CDC, Rare Disease Policy Division. We worked with Down Syndrome associations. Together, we made a 3-minute awareness video featuring a young adult with Down syndrome. We also held a joint dissemination event. The goal was simple: raise awareness and push for inclusive health policy. Although funded as a rare disease project, it also supports maternal nursing by promoting inclusion for mothers, babies, and families. Name is 우리 다운 이야기. We can see on the YouTube. Our Down story with the Korea Disease Control and Prevention Agency. Sometimes mothers realize that their babies have Down syndrome. Doctors urged to abortion to mothers. But some mothers, I want to see just one day only. I want to have a baby. And at that time, doctors also 반성하다. Regressed why they urged to abortion for mothers. So, and in this video was very impressed to many people. Yeah, next one is global nursing leadership and interdisciplinary collaboration. Just you can see international collaborative program with IPON. And I think a key leadership component, connect plus means more and more connect to others. To make this full vision, I did not just delegate tasks. Together with the academic directors, agent, and the secretary general, we held meetings every Tuesday for performances. this e-fund was very successful. 2,200 participants in COEX in Seoul. This is an ongoing international collaboration of 14-country study on the mistreatment of pregnant women. I'm reading the Korean arm, measuring how often it happens and what forms it takes. Recently, my lab team contributed to this effort by submitting 2 abstracts to the upcoming academic conference. In addition to global conferences and multinational projects, I'm also engaged in personal collaborations with professors from the University of Tokyo. I'm working on the translation of previous PUBRAS K23 item. I'm also participating in the Aspire Japan project, specifically in the Digital Twin Initiative. And last photo is participating in research exchange forum at my university level, where I collaborate with the top scholars in AI. Through these meetings, I'm seeking new ways to visualize and innovate nursing practice. Finish it? Yeah, thank you. Thank you very much.
Thank you so much, Dr. Chung Kim. I apologize for the mispronunciation at the introduction. Apparently, my brain didn't wake up yet from lunch, so I apologize. And at this time, we will present the plaque to Dr. Chung Kim. If you could please join us in the front.
Thank you. It's for you.
Okay, that concludes our final presentation for the day. So thank you everyone for sticking around and enjoying all of our presentations that were presented here today. We're going to take another quick break and be back at 2:45 to continue with their question and answer session. And we will be inviting all of the speakers back at that time at 2:45 for Q&A session. So feel free to take a quick break and then join us at 2:45. And if you have any questions for Dr. Chung Kim, please submit them to the check-in desk and or virtually at the YouTube link. Thank you. Good afternoon. Can you hear me? Can everybody hear me okay? Good. I'm really loud without the mic, so I'm sure you can hear me, but please let me know if you're having a difficult time hearing me. So welcome back to our Q&A panel featuring all of our today's speakers, Dr. Michael Chung, we have Dr. Haewon Kim, we have Dr. Amaporn Ratenthorne, Dr. Fan Hao Jo, and Dr. Chung Kim. So I got that right this time. And we also have Dr. Reiko Sakashita joining us from
Yes,
Japan
nice.
on Zoom.
Yeah.
Hello.
Hello. Hi.
Great. Well, thank you all again for your wonderful presentations today. I learned so much from all of your presentations, and I'm so inspired by all of your, your stories and your experiences. So I am truly grateful for you being here today. So we're going to start off with some questions, and I'm going to maybe start off with Dr. Chung, and maybe I'll just go down the line. And you shared about your experiences in Africa, but you also shared that you did some work and lived in Vietnam. And so I'm wondering if you could maybe share a few similarities or differences between these two healthcare systems and populations.
Yes, that's a great question, and I think there's a reason why I also didn't put it in the same category, only because one of the things that I found very quickly is I thought, oh, I have spent so much time in Kenya, 8 years before I went to Vietnam. I've been doing HIV medicine in this lower resource setting, and I thought I knew what global health was, but I was stunned in a very good way that when I went to Vietnam, it was completely different in terms of now what the disease meant, how the systems were set up, and how people were being treated. And so I had to really myself take a step back and say, wow, when we talk about global health, there is an injustice to now paint it with the same brush. That with a different country and a different system, it's a completely different approach that has to be understood and has to be learned. And so I had to learn really from scratch, not even just HIV medicine, so for example, there are diseases that we see in America and Kenya, like Kaposi sarcoma, that they have never seen out in Vietnam. And similarly, they see diseases that we have never seen in Kenya or America, like Penicillium marnefii, which is obvious to them. But those things I had to learn, and it was a great exercise in now saying, wow, I just have to understand now how Vietnam works, what will work here is very different than what I could assume in Kenya. I think I'll leave with an example that when I was there, we had set up a sort of visit for one of the ministers, the Minister of Health, and the team to now visit Kenya. And we thought, oh, this is great. They'll come and they'll see many things that we do in Kenya, and maybe they'll learn from now how we approached it at the Coptic Hope Center, other things. And then they came back from that visit, and we were very excited. I said, oh, wasn't it great? Didn't you learn how we do things? Isn't this helpful? And they said, that was so bad. And we're like, whoa, what happened? They're like, that was so terrible. I was like, what? Why? And what they had seen was that, and which is that they couldn't understand why in some of the poorest areas we did not have clean water, why we did not have good sanitation, why we had sewage systems that were open. Because in this communist country, was not something that was there. And yet it is something in the capitalist country of Kenya we had. So it was like, wow, yes, that's true too. So these basic systems they had taken care of is something that we still struggled with in Kenya, despite us both being considered lower middle income countries.
Right. Well, thank you for sharing that, and that really goes to to show how important culturally congruent care is and the context that we're delivering the care. So thank you for sharing that. And I have so many more questions, but since we don't have a whole lot of time, I'm going to maybe ask the questions for the rest of the panelists, and then at the end we'll see if we can open it up to audience questions. So my next question is for Dr. Haewon Kim. And I was just wondering, particularly in terms of nursing education, how can nursing education and practice be strengthened to address disparities in prenatal care, especially in underserved and resource-limited settings?
Well, from my presentation, I took the useful framework or strategy that is social determinant of health and interprofessional collaboration. So using those approach, we can do a very clear and very confining a target population, and which is the most urgent issue for them. And the diagnosis and evaluation, the issue should be made from their point, not the healthcare provider, I think. That is more important. That could be culturally adaptive and sensitive, and it could be very appropriate way, I think.
Great, thank you.
No?
Great. Okay, we have our next question for Dr. Amiporn Ratenthorne. As the Dean of Mahidol University, Faculty of Nursing, and Global Leader in Nursing Education, how do you envision collaborative partnerships, such as those between your university and institutions like ours here at UT Austin School of Nursing, playing a role in preparing future nurse leaders?
That could be the next step that we think about the collaboration in the solid plan. But I can give you some example about what in the previous experience that we're trying to develop the leadership in our nursing undergrad. We developed the program called Asia Pacific Alliance for Health Leader, and that's called APAL. We used to have like Thai, Korea, Australia, and Japan come for the workshop, and we take turn, and students learn about the leadership. That's probably maybe thinking about coming together with us with the same purpose that we would like to, for example, we would like to make the visibility of, the economic power of nurse. So if you think this is the purpose that we would like to make, the world understand that this is the nurse contribution as an economic power, we can come together at a workshop, learning how to think and how we can teach students to understand about what is the outcome of this, and step by step, like for the student graduate student, and even in the doctoral program, they can learn about evaluation research. So if we see this is we have some common interests, and we can collect the partnership. Is like if UT Austin would like to start this workshop together, that will be starting point that we can create. That's one aspect.
Great, thank you. Looking forward to it. I'm sure Dean would approve of us initiating this partnership, right, Dr. Im? Great, thank you. Then I have my next question for Dr. Fan Hao Cho. With your leadership in nursing education across Taiwan and your academic experience here in the United States, specifically at UT Austin School of Nursing, what do you believe are the most impactful ways to align nursing curricula globally while respecting cultural and systemic differences?
Okay, I think maybe we host interprofessional courses is very important. So, for example, in KMU we have a course called Culture and Health, and this course we open to our student from Taiwan student and also from United States Georgia University. So there are faculty every year bring the student to come to Taiwan, and we study together. So and we understand each other. So that will be very interesting and very powerful. And another is now we are still doing for the IPE courses is for ethics. Including nursing and pharmacist, both KMU student and UAMS student, Arkansas student. So every year, every other year, they will come to KMU. And every other year, KMU will come to UAMS. So to study the interprofessional education and plus using problem-based learning. So I think they will know each other, including the culture and the different culture, different country. They are different, and to know more comprehensive. I think this is maybe more global impact to our new generation. So I think for our experience, I think that's maybe is a one of the good strategy.
Yes, thank you. Yes, and I think interprofessional collaboration is so important.
Yes.
And I really appreciated your presentation today, Dr. Chung, for highlighting the contribution of nurses in providing and promoting health. So, I think, like you said, Dr. Joe, I think, interprofessional collaboration is so important, and for us to get to know each other's roles better so that we can provide the best care possible and achieve the same goals as whether you're a physician or social worker or physical therapist or nursing. So that's really great to know. Thank you. Great. Our next question is for Dr. Reiko Sakashita.
Yes.
Thank you for joining us.
Yes, thank
And
you.
we really enjoyed your presentation earlier today too. So we're really happy that you're able to join us here on Zoom. And given your expertise in gerontological nursing and global health, what strategies or educational innovations would you recommend to better prepare nurses, both in the US and globally, to meet the complex needs of the rapidly aging population?
Thank you very much for your question. Because gerontological nursing is needed in every settings, acute care, chronic care, and home care, I recommended integrated it across the curriculum. In other words, gerontological content should be woven throughout all year of study and across all clinical placements. One useful approach is to assess competence through OSCEs that include comprehensive gerontologic assessment with patients experiencing dementia for prevention, polypharmacy review, and advanced care planning. So interprofessional collaboration is essential in elder care, in particular by providing interprofessional education focused on care transition from hospital to home. Students can be expected to run team-based and community-based models. So recently, in addition to cultural competence, more attention has been given to cultural humility. Using a case study that innovate community and family situations can be an effective way to teach this concept. In Japan, it seems that the need for nursing care is shifting from hospital to community. That was common in worldwide, and many students grow up under their parents' protection and become adults without real life experience of meaning the hardship of daily living. And so our university, we provide a community health practicum in the first year. Through this practicum, students learn about individual livings in the community, that their health issue and the reality of daily life, including those affected by conditions such as dementia. So they also come to understand the importance of interprofessional collaboration with professionals in medicine, pharmacy, rehabilitation, and social work.
Great, thank you. And I can see that the whole concept about interprofessional collaboration really, applies to all of our speakers here. But I just wanted to point out what Dr. Sakashita mentioned that just really kind of, came to heart for me, which was, the transition from cultural competence to cultural humility. So I thought that statement was really powerful. So thank you so much for that, Dr. Sakashita.
Welcome.
Okay, and last but not least, Dr. Chung Kim. And our question for you is, as a leader in nursing science and maternal health, how can we better integrate evidence-based research into clinical practice to support women's health across the lifespan? And what role do professional societies and academic journals play in shaping global standards and advancing innovation in nursing care?
Thank you for question. Actually, I listen well from many people, and I attended some academic event also. So when I realized, oh, it's a very new idea or some kind of challenge to nursing, and I suggest how about to write an editorial or some paper to our journal. So I invited to their ideas to visualize some papers. So, and then when I visited some clinics, and I it's find something to develop to measure. It's not real. Exist previously, and I suggest again. How about develop some scale measurement? So and then developed one is delivered to clinic. Head nurse was some team manager, and it's adapted that measurement scale to use in clinical setting. So I do not insist some decided format or traditional format. I do not insist. Just something isn't new or some challenge is very important to our nursing academic society. So I aimed to visualize something we do every day in nursing care, and make visualize paper or some scale or some practice. So like that, yeah, I integrate many things to our nursing practice or nursing education.
Yes, and I think it's really important to, talk to the frontline nurses who are providing the care to the patients. They know the ins and outs of how to deliver that care, so they're like the experts who can bring their ideas forward, the new innovative ideas forward. And so I think it's really important not to just partner with only, academic researchers or faculty members, but also to work and collaborate with like the clinicians who know patient care, right? So that we can better take evidence from what's in the literature and apply it in the practice setting.
For example, I can say, for example, NICU nurse realized there is no assessment scale when is the very best time point to oral feeding. And then she did not know what is that. So, and I worked together and developed some oral feeding readiness scale. So, like that.
Great example, thank you. And unfortunately, we're already over time. I'm really sorry because I'm so interested in learning more and just having further dialogue. But I do want to open it up to audience question. Maybe we have time for like one quick question if anybody's willing to ask.
Hello, my name is Victoria Bailey, and thank you for all being here. My question is about non-licensed nurses in your country. That would be nurses' aides, nursing techs, care partners, medication aides, especially when we look at vulnerable communities. We need many extenders beyond the nursing role. And my question is, what kind of education and training and support and infrastructure do you have to develop that workforce? Especially someplace said that 54% of midwives were retired, but to bring up some people who can assist the nurses that are there and the physicians. Thank you.
I think anyone can answer.
Okay, may I? Well, in Korea, we have a nursing aide in our healthcare structure, but their training and education usually done at the level of the private institution, not the regular academia. But for a long time, we continue to do that. But sometimes some textbook for them given the lecture by the nurses, but we cannot exactly estimate how was happening in there. But we do not touch enough because the borderline or is very clear between our profession and occupation. So when sometimes we can struggle each other for some reason, but usually we are doing our work. But without the nursing aid, now in Korean society, a growing number of elderly group, and the number of the elderlies are going to nursery. The nursery system usually hiring the much of non-nursing. Okay, so but I'm not so interested in. I'm not expert about that. The workforce of nurses, but in the government level, how to regulate their system, including workforce, how they regulate or certificate, how can they control. But now we are establishing states, I can say. But I expect the growing number of the non-nursing infrastructure could be possible, and sometimes we make some negotiation and we can collaborate. But actually, the collaboration is necessary regarding this RN or not. This is our reality.
Did anyone else want to add anything?
We also have nursing aid training course. So they have to pass the examination from Ministry of Health and Welfare. So because I think the nurse shortage issue also in Taiwan is very important. So we need more nurse aid to help to do something not a professional job. So now we have this kind of training course because we want to make sure the nursing aid is good enough to help our nurses. So thank you.
Thank you.
Example. Recently, actually last month, long before we have 2 years ago, we opened the clinic called Midwifery Nurse and Midwifery Clinic as a primary clinic from our Faculty of Nursing. And we work, collaborate with, as a partnership with the community around the clinic. And we know that the elderly people need caregiver. And that's, so we developed the project. We upskill the caregiver. It could be like volunteer, health volunteer, who work in that area. It could be the family member that would like to learn about the care, how to take care of the elderly. It could be like, you know, the person who would like to learn about taking care of the elderly. So we get together, we provide 2-day workshop and to teach them how to take care of the elderly, how to move, how to, you know, in the critical, you know, we can CPR and caring for like the wound care. And, you know, it's turned out that they're all happy. They know how to talk with the elderly. They know how to take care of the elderly. This kind of upskill is fit with our vision that we would like to transform healthcare and well-being. And we think that upskill people in community to be like a caregiver, to have skill and, you know, learn how to take care of the elderly is one of the, you know, the activity that we should do for the society. So we provide the workshop, and we got funding from, you know, the local government in that area to support for the, you know, budget. And I think this is the second year that we run this workshop. And we have not only the you know, the trainer, the person who attend the workshop who be able to have skill to taking care of the elderly, but we also have network to connect more people to come to the workshop.
Great, thank you. I think these were really great examples that they've shared, and I hope they were able to answer your question. And unfortunately, we really don't have any more time. I apologize. I really would like to continue this discussion, but I do want to get everybody out on time. So at this time, please give another round of applause to all of our speakers. And thank you all, to all of our speakers who've, provided such meaningful and insightful input and discussion and share your experiences with us. And I'm sure, we have a lot more questions to ask, but if it's okay for us to reach out to you, if we have, some burning questions that need to be answered, we'll be sure to reach out at a future time. But thank you so much for your time and for being here with us today. Okay.
Thank you.
Thank you. I have one final closing statement before everyone leaves. And